in 2022 because I was in sick leave. I was in intensive care in the beginning of the last night in the 2021. So that was my end of 2021 after a hectic year. And thanks God, I'm back again. I have time to go with you again. And all the praises to your dua and your prayers. And thank you so much. We have another go, and I hope I will pass the next step after 1 month. I have more investigation to do, and hopefully will be clear, and we'll continue together. Thank you so much for your dua and your prayers. Include me again in your prayers again, and we'll continue. After 30 seconds, Mustafa will going to continue the program. This program tonight is co-chaired by Mustafa Hilal and Dr. Yasser Daghlul, and I couldn't find any better moderator than those two iconic figures. I will display the survey later on, Google survey. Please fill it, because Professor Ines Kamel always asking for the survey and how the program is evaluated to be able to continue, because this program is considered #1 sources, online sources for the medical doctor for fellowship study. Thank you. Mustafa, you can start now. Thank you so much.
Okay. Good evening, everyone. It's a great honor for me to participate in this great symposium today about coagulation. And it is a great honor also to be the first one to introduce that our return back to our mega scientific courses in 2022. Firstly, it's a great honor for me to introduce my great prof, Dr. Yasser Daghlul, will present a case discussion. Really, Dr. Yasser worked as a senior consultant of anesthesia in Sheikh Khalifa Medical City. This is the back of hospital at night. His subspecialty is pediatric anesthesia, neuroanesthesia, as well as neurocritical care. Of course, is a perioperative medicine, and ERAs are another important issue in his scientific journey. Welcome, Dr. Yasser.
Okay. Thank you so much, Professor Safa, and I'm very happy to share in this symposium. And we will start just something very little exercise before going to the heavy lectures with other speakers. So this is a very short communication, about 8 or 10 minutes, about case presentation of a patient on oral anticoagulant, and the patient is coming for emergency surgery. She is 93 years old lady and hypertensive, and ECE inhibitors and calcium channels blocker. On the same time, she is hypothyroidism in thyroxine 50 mic OD, atrial fibrillation on epixaban. This is a problem for us now. And she is 2.5 milligram BID. She has history of transient ischemic attack twice, but fortunately she has complete recovery. Of course, the origin of this transient ischemic attack from some microthrombi in the left atrium, which migrate to the brain. That's why they increased the oral anticoagulant, or I think it was changed from warfarin to epixaban. She has history of hip fractures, and it was done under spinal anesthesia without problem. At the same time, she is a bedridden, and she has chronic hyponatremia, and it may be from malnutrition. Now this patient came for ER, and she is disoriented or drowsy, but not talking, hypotensive, a little bit tachycardiac, and atrial fibrillation in her ECG. saturation 100% on face mask with 40% oxygen, chest bilateral lower zone cracks, which is more in the left side, and the abdomen is soft, not tender, bilateral lower limb edema. And this is the problem now. Grade 3 pressure sore over sacral area, infected and necrotic. So this is the source of septic shock or sepsis. And she is diagnosed of septic shock secondary to the infected bed source. This is, as you see, it is around 30 by 25 bed source. That is a major bed source. As can you see, it is very necrotic and very bad smell. Leukocytosis, anemia, platelet is okay. INR, of course, because of oral anticoagulants, 3.8. EBTT is prolonged to 63. Hyponatremic 131. And potassium 5.2 borderline, and there is moderate increase in both urea and creatinine. So what is your management in this patient? Should we reverse here now what you are going to do? I will give you some idea about what we can discuss about in this patient. First, we have two major issues. As you know, the patient on oral anticoagulant with prolonged coagulation profile. At the same time, septic shock per se causes coagulopathy. Even if the patient is not at anticoagulant or heparin or whatever the medication, there is a risk of bleeding and coagulopathy. Because you see, it is very huge area, should be debridement and should be removed. Later on, the patient with septic shock may develop disseminated intravascular coagulation. But our problem now about the epixaban, which is potent, highly selective anticoagulant, and the main action, direct inhibition of activated factor 10, which is the end point of both intrinsic and extrinsic coagulation pathway. At the same time, epixaban has another effect by reducing the thrombin generation and inhibits thrombin-induced platelet aggregation. So 3 effects for this medication. And the most common use, prevention of thrombosis in patients with acute coronary syndrome and atrial fibrillation. As all oral anticoagulant, we should consider the drug interaction with the other categories. Some dual inhibitors increase the risk of bleeding. That means it is competing at the same site of metabolism, this cytochrome B3A4. That's why increase the plasma level of epixaban, like diltiazem, non-steroidal naproxen, antifungal like ketoconazole, antiviral like ritonavir, and clarithromycin also may be the problem. Other medication may induce the cytochrome B3A4. That's why the metabolism of this medication will be high and the plasma level will be low, and the antithrombotic or anticoagulation effect will be reduced, like if the patient taking rifampicin, phenytoin, or carbamazepine. So in short, any patient on anticoagulant, whatever direct anticoagulant or vitamin K antagonist like warfarin, you have to put in our mind the drug interaction. A very quick idea about the metabolism of epixaban after GIT absorption and going to the circulation. About 25% is eliminated from urine and 75% from the bile and stool. Now we saw the patient in ICU. General measures for septic shock are given, of course, early use of antibiotic, intravenous fluid resuscitation, nor epi was start at 0.7 mic per kg per minute, still an oxygen mask, which is satisfactory in 40%, because hemoglobin was 78. She started blood transfusion, 1 unit is given and the second one is running, still drowsy but communicating. And we have, of course, high-risk patients. So we have team discussion between anesthesia, ICU, surgery, cardiology, and the neurology about the how, when, and how to reverse this oral anticoagulant. You may ask why neurology? Because I mentioned earlier, she has 2 transient ischemic attack. So if we stop the anticoagulant, there is still a risk of stroke. That's why we included the neurology. The end result of this discussion, we have careful or even partial reversal of the epixaban, and of course, bridging to the low molecular weight heparin after surgery. So my question now, when and how we should reverse the patient? Should we reverse here in ER, in ICU, or in OR? If she come to OR without reversal, I do the reversal with induction or intraoperative. What should I give? Vitamin K, tranexamic acid, FFP, cryo, prothrombin complex concentrate, 4 factors, BCC, this is the same, but high level of factor 7, or fibrogen concentrate. Fibrogen, as you know, specifically used in patients with hypofibrogenemia. So we can exclude the fibrogen. So our option now, FFP, cryo, prothrombin complex concentrate, and the 4-factor BCC. All of them are proved to be effective in the reversal of oral anticoagulant with some degree of success different from one to other. And we selected to use it intraoperative. This is our decision because we let the surgeon to start and to see what is the bleeding. If it is significant high bleeding, we should reverse either full reversal or partial reversal according to the clinical surgical bleeding on site, not blindly to reverse it. So anesthesia is usual etomidate, sofentanil, ketamine. Because she is in lateral position, we use the laryngeal mask. It is maybe discussion to intubate or use laryngeal mask because this is very old lady and maybe intubation cause post-operative ventilation. And we arranged with surgeon to put him in semi-left lateral position. So there is no problem from LMA. And because of anesthesia, we have to increase NOR-AB to 1.2 mic per kg per minute. During starting the surgery, there is a moderate bleeding. And this time we start to reverse and we give 25 units per kg to reverse the epixaban. At the end of surgery, there is excellent hemostasis and back to ICU. And you can see the difference now after surgery and very wide raw area, maybe now 40 by 40. And you can see excellent hemostasis and no microvascular bleeding. So to know what we are the anesthesiologists doing when facing something like that, in this survey management of oral anticoagulant prior to the emergency surgery with major bleeding. What is the practice? You may ask yourself, your colleague, you will find a lot of different answers. That's why they did this survey under the American Society of Anesthesiologists, and they included more than 2,000 patients and included 22 questions. And the questions that you are using prothrombin complex concentrate or FFB to reverse the anticoagulant for patient coming with severe bleeding or coming for emergency surgery. As you see, most of the responder using the FFB. This is the blue one. And the BCC, this light blue, in about 1/3 of the patient, 2/3 of the physician, whatever ICU or anesthesiologist are using FFB. This either to reverse vitamin K agonist like warfarin or direct oral anticoagulant like epixaban in our patient. And the other issue, they found that only 32% of the hospital have a protocol to reverse the anticoagulant. And 64, they don't have just coordination. As actually in my hospital, we don't have a protocol. As we discussed with all the team involved in the management of patient, and we take our decision. So in short, maybe it is better to have a protocol or some local guideline to reverse the oral anticoagulant. How much should I give? According to the American Thrombosis Society, recommended doses according to the INR, between 2 to 4 to give 25, between 4 to 6 to give 35, if INR more than 6 to give 50. We used in our patient 25, which is very effective in reversal of the anticoagulant. The second point, as you know, sepsis-induced coagulopathy, this is because 3 main problems: coagulation activation, endothelial cell damage, and the platelet aggregation. All these problems may cause DIC and coagulopathy. Even the patient not in anticoagulant, we have to consider it in patient with sepsis or septic shock. Later on, if the infection is so severe and or not treated well, it will progress to disseminated intravascular coagulation, and of course, this hypercoagulable state and causing microthrombosis and multi-organ dysfunction. Third point, major surgery per se may cause consumption and dilutional coagulopathy. And even this patient, not in sepsis or not in anticoagulant, and she have major surgery, she may develop consumption or dilutional coagulopathy. And this, of course, precipitated with other factors like hypothermia, acidosis, anemia, and hypocalcemia. Now, I think a lot of you asking if this patient on anticoagulant and she may be a candidate for neuroaxial or regional anesthesia. How can I manage this patient? It is a very small question, very big answer. The answer comes this month, just published 2 days before, about the recommendations by the European Society of Anesthesia and Intensive Care in combination with the European Society of Regional Anesthesia, as they published 40 recommendations. Actually, I didn't read all. It is very confusing. More than 33 pages. It may need 2 days to finish it. But I recommend every person that he have regional or neuroaxial anesthesia in every routine work every day to read these recommendations. I may maybe summarize it later on, but anyway, you can read it. It is free, available online. So in short, FFP cryoprothrombin complex for factor BCC can be used for reversal of vitamin K antagonist and the oral anticoagulations. Patient with severe sepsis may develop coagulopathy and he may need other measures. You may need to transfuse platelets, for example. Post-operative bleeding may occur after major surgery due to the consumption and dilutional coagulopathy. And thank you very much for your attention, and hope you are ready for the other lectures. Thank you, Dr. Safa.
Yes, sir. Elegant case. Now we will introduce Dr. Wissam. Dr. Wissam Sultan is Associate Professor of Anesthesia, Intensive Care and Pain Management, Monofia University. Really, he's my elegant colleague. He had a European diploma of anesthesia and a member of European Society of Regional Anesthesia and Egyptian Society of Anesthesia also. His subspecialty in regional anesthesia and bariatric surgery, his private work in ABC Center for Bariatric and Plastic Surgeries. Welcome, Wissam. Really, physiology of coagulation, I called it previously as the figures of arrow. Many arrows transferred from during the normal process of coagulation. What happened? Also, what happened in coagulopathy? He will clarify this point. Okay, Wissam. Wissam?
Wissam, unmute yourself, please. Yeah, unmute yourself now. Sorry. Okay. So, yeah, so you're okay now. You should be okay now. Can you share your screen, please?
I will. Thank you.
That's perfect now. We need to mute one and get one ready.
Okay, I will mute this.
Yes. Okay, take your time.
Bismillah.
Should be perfect now.
I have a problem, sorry.
Okay. Can you share your screen from the computer?
I lost already that in my computer.
Yeah, you know,
I lost-
just take your time. Sometimes it happens.
Bismillah. I will join again.
Yes, please do.
Bismillah.
We apologize for any technical issue here. Sometimes it happens despite
I'm
all
sorry.
preparation.
Okay. Are you with me now?
Yeah, we hear you, we see you, but we
You
need
see
to
me?
share your screen.
I want to share. Bismillah. Where is it?
So, is it difficult to share?
Sorry, Dr. Saad.
No problem, no problem. We just need to know because the Zoom time.
I'm sorry for all.
No, not at all. Not at all. Okay. Can we?
We can see another
wait,
speaker.
yeah.
Because the
Please,
time.
please, because I have a problem. I'm sorry.
Okay. Okay.
Yeah.
That's fine. Who's next? Okay, he's here now. Okay, lovely. Dr. Wissam is sharing.
I'm here, but I cannot. The sharing the
You
screen.
were
I have.
sharing. You shared already your screen. Okay, so we can move to the next speaker if you don't mind, please.
Yeah, please.
Okay.
Who's the next speaker, Dr. Safa?
Okay.
Okay.
Now we have.
Dr. Ahmed, are you ready? Is Dr.
Okay.
Ahmed ready? Dr. Sawi.
Dr. Ahmed Sawi, are you ready?
Yes. Yeah.
Okay. I have a great pleasure to introduce one of the promising anesthesiologists becoming one, Dr. Ahmed Sawi, at the MRCP, European Diploma of Intensive Care, Master Degree of Anesthesia, Lancashire Teaching Hospital Trust, UK, the Egyptian. He has MBCH Cairo University, Egypt, Master Degree Intensive Care in Ain Shams University. Please. His valuable topic today is about the pharmacology of anticoagulant. Yes, Dr. Ahmed.
Thank you, Dr. Safa. It's my honor to be involved in this talk with incredible group of professors. I'm still young compared to your experience. I'm trying to.
Can you make your slide share, please? Slideshow.
Is it shared now?
No, it's shared, but we need the slideshow.
Yeah. Is that okay now? Yeah. So
yes.
So my talk today, it's almost purely academic. I hope it will not be boring, but it's very important, as Dr. Yasser has presented a clinical scenario which everyone could face in reality. So I'm going to talk about pharmacology of anticoagulants. So learning objectives, sorry, I will just revise this one. Yeah. So to explain types of anticoagulants, to understand the mechanism of action of these drugs, pharmacokinetics and pharmacodynamics, and the role of anticoagulants and their uses, and to highlight the adverse effects of anticoagulants with some of them have already reversal agent and some not. So classification of anticoagulants, there are multiple classifications. You can classify anticoagulants depending on the mechanism of... sorry? So you classify anticoagulation, multiple classification could classify it as oral or parenteral, or depending on the mechanism of action. So the anticoagulants generally, whether they interfere with the synthesis of coagulation factors or interfere with the action of coagulation factors. So we have, like on the right side of the screen, a vitamin K antagonist, and the father of them is a warfarin, and heparins and heparinoids. We are almost using sorry, Dr. Saad, are you talking to me?
Go ahead.
Do you hear me?
Yeah, I do hear you. Thank you. Go ahead.
Okay. So we have heparins and heparinoids, such as unfractionated heparin, which is still widely used in our units, and low molecular weight heparin, such as enoxaparin, dalteparin, and tinzaparin, and fondaparinux. Direct thrombin inhibitors, we have intravenous bivalirudin and lipyridine and algatropan intravenous, and the oral drug like dabigatran. And new oral anticoagulant or novel oral anticoagulants, which are direct factor 10 inhibitors, such as apixaban, edoxapan, and rivaroxaban. So just to refresh your memory with unfractionated heparin, it's glycosaminoglycans. It has like wide range of molecular weight, an average about 15,000 Dalton. The mechanism of action of unfractionated heparin, it acts mainly through antithrombin 3 complex, and which in turn forming antithrombin heparin antithrombin complex that attach to thrombin and cause and stop activation, stop its action. And you see on the right side of the screen the heparin, unfractionated heparin, mainly inhibit the thrombin and factor 10 through the antithrombin complex. The heparin also inhibit factor 9, 11, and 12, but the main action of it on thrombin and factor 10. It has another ways of action. It acts as a catalyst through heparin cofactor 2, and it has a modulation. It causes some modulation of factor 10 generation, but to do this, it needs to be a very high concentration, which is clinically insignificant because it's not practical. Pharmacokinetics behind unfractionated heparin. Heparin, we don't see unfractionated heparin orally because it doesn't cross membranes. It is not absorbable, and it doesn't cross placenta, so it's safe in pregnancy. It is highly bound to proteins, which means it gives it a range of and variability of pharmacokinetics. Metabolized by reticuloendothelial system in circulation. It doesn't have any renal renal excretion in unchanged formulation. So no dose adjustment in renal impairment and can be used safely in a renal impairment patient. The main adverse effects of heparin, of any anticoagulation, first, hemorrhage. And heparin is the commonest drug that can cause heparin-induced thrombocytopenia. And heparin itself can cause hypotension, especially when we give it in theater. Sometimes the bolus and vascular surgery can cause hypotension, osteoporosis with prolonged use, hyperkalemia, and heparin resistance, mainly due to deficiency of antithrombin 3. So compared to unfractionated heparin, we are widely using low molecular weight heparin, such as enoxaparin, dalteparin, and tenzaparin. It's a natural derived from heparin by depolymerization. Its low molecular weight, its molecular weight average 5,000 Dalton. Advantages over unfractionated heparin that in subcutaneous injection, it's better absorbable than the heparin. So it has also a predictable pharmacokinetics. Less effect on platelets. Reduced risk of HET or heparin-induced thrombocytopenia. It causes already, but it is less risk than unfractionated heparin, and reduced need for monitoring. But we need monitoring for low molecular weight heparin in some patients, as in very obese patients, or in some patients with renal impairment or risk of bleeding. Mechanism of action of low molecular weight heparin. In the bottom of left side of the screen, you could see low molecular weight heparin has almost 1/3 the length of unfractionated heparin. It combined to antithrombin, and it formed the antithrombin complex that inhibit factor 10. It has also an action on factor 2, but its main action on factor 10. It's about 4-2 in action. So on the right side of the screen, it's brief comparison between unfractionated heparin and low molecular weight heparin. Absorption from subcutaneous injection is better with low molecular weight heparin, and bioavailability is higher with the low molecular weight heparin. Half-life of unfractionated heparin is about 1 to 2 hours, with average 1.5. And low molecular weight heparin, it's 3 to 12 hours with normal renal function, and half-life is prolonged in renal impairment. Unfractionated heparin metabolized mainly by reticuloendothelial system, and low molecular weight heparin has a fraction that renally excreted. That's why it requires dose adjustment in renal impairment, and there is some advice to avoid it if eGFR less than 15. Both are safe to be used in pregnancy. Monitoring, ideally, unfractionated heparin should be monitored by anti-factor 10 level, but most of units, critical care units, have a target of partial thromboplastin time, with targeting 1.5 to 2.5, and they have different units have the protocol for adjustment of the heparin infusion dose according to the PTT. But low molecular weight heparin is targeting anti-factor 10, and because it will be measured 4 hours post-dose, because the Cmax, or the highest level low molecular weight heparin, about 4 hours post-injection. Antidote of or reversal for unfractionated heparin will be protamine in about 1 milligram for every 100 units. Low molecular weight heparin, protamine can cause partial reversal, roughly about 60%. Heparin-induced thrombocytopenia, one of the complications that could happen from using heparins and low molecular weight heparins in the intensive care units. It occurs about 5% of patients who were exposed to heparin, but it carries mortality of 30%. It could cause widespread thrombosis and consumption of platelet. The mechanism of the HET is the immune head or the type 2, because we have two types. Type 2, which is the immune one, heparin bind to platelet factor 4 and causing heparin platelet factor 4 complex that in turn will bind to immunoglobulin G, and this complex will attach to Fc receptors on the platelet, causing triggering platelet activation, which in turn will cause like loop activation of the cycle and release more platelet factor 4, and so the cycle will continue and will lead to consumption of platelet and widespread thrombosis. So we have type 1 and type 2. Type 1 usually happens. Usually it happens 1 to 4 days after you starting heparin, but type 2 typically between 5 and 2 weeks. And type 1 is non-immune, and type 2 is immune mediated. Type 1 usually it's benign and you don't need to discontinue heparin, but type 2 you need to change heparin to one of other agents like direct thrombin inhibitors or fondaparinux. So back to it, there is a 5T score system that we use to evaluate the probability of heparin-induced thrombocytopenia in each patient. Fondaparinux is one of the synthetic, it's chemically related to low molecular weight, but it's chemically related, but it is different in structure. It is synthetic pentasaccharide. It selectively inhibits factor 10 through antithrombin 3. It has longer half-life, 17 to 20 hours. It's elimination in the body dependent on renal clearance, so it's better to be avoided in case of eGFR less than 30, also in elderly patient, and in low body weight below 50 is better to be avoided. The main adverse effect of fondaparinux bleeding, there's no specific reversal to fondaparinux, but still potamine could help in reversal. And fondaparinux, as we said earlier, it is less likely to cause heparin-induced thrombocytopenia. It can be used for prophylaxis and treatment of venous thromboembolism and pulmonary embolism and myocardial infarction. Moving to direct thrombin inhibitors. Direct thrombin inhibitors, they have direct action on thrombin or factor 2A. Not dependent on cofactor or antithrombin 3 levels. So they also less likely to cause a HIT, so can be used if there is a patient suspicious or at risk of HIT, so they can be used. Predictable pharmacokinetics, short half-life. If we're using the intravenous direct thrombin inhibitors, they have shorter half-life. And the parenteral still there's no optimum reversal agent for direct thrombin inhibitor. There are different ones of direct thrombin inhibitors intravenously. This is a comparison between them, lipyridine and desirodine and bivalirudine and algatropan. Maybe bivalirudine can be used in ECMO circuit, on ECMO circuits, and in patients at risk to develop HIT who is going to PCI. Algatropan can be used in case of a patient at risk of HIT as well, if he's going to PCI. I will not go through everything on the slide for the sake of time. However, you will notice that plasma half-life it's short. Bivalirudine is about 25 minutes, and algatropan is about 45 minutes. And metabolism is of them dependent on lipyridine, dependent on renal excretion, and algatropan dependent on hepatic excretions. So cautious to use algatropan in patients with liver failure, and cautious with bivalirudine in patients with poor renal functions. So to summarize the comparison between parenteral anticoagulants, we have unfractionated heparin, we have low molecular weight heparin, fondaparinux, algatropan, and bivalirudin. Mainly what you need from the comparison, because it's detailed comparison. You need to know at least the half-life of them. So unfractionated is about 1 hour. Low molecular weight 3 to 6 in one resource, and another resource is up to 12 hours. It depends also on the renal function. Fondaparinux 17 to 21, algatropan 45 minutes, bivalirudin is 25 minutes. Regarding the monitoring, unfractionated heparin, antifactor 10A and PTT, low molecular weight heparin, antifactor 10A, but not routinely. We monitor low molecular weight heparin unless, as we said earlier, there's an indication or patient at risk of bleeding. Fondaparinux, antifactor 10A can be used to monitor fondaparinux, algatropan, PTT, and bivalirudin as well, PTT. Risk of head higher, the highest with unfractionated heparin, less risk with low molecular weight heparin. But in case of patient suspicious of head or 40 score show the high probability of head, then we will change to other agent like direct thrombin inhibitors or fondaparinux. Dabigatran etixalate is a direct thrombin inhibitors, but taken orally. It's a prodrug. It is converted into dabigatran. Bioavailability is 6 to 7% and decreased by using proton pump inhibitors. One third of the drug will be bound to plasma protein. It is metabolized in liver and elimination in biliary, mainly renal 80% and biliary in 20%. Half-life 12 to 14 hours. It can be used to prevent venous thromboembolism after heparin knee replacement, and treatment of venous thromboembolism and prophylaxis and prevention of stroke and thromboembolism in non-valvular atrial fibrillation. Because elimination, it depends on renal excretion, so dose adjustment in renal impairment is required, and it's oral drug, and it doesn't need to be monitored. In case of serious bleeding happen, so either eculizumab can be used for reversal, but I know it is very expensive and not available everywhere. And it has some drug interaction, so like amiodarone and verapamil, so you need to pay attention to drug interaction. So novel oral anticoagulants or direct factor 10 inhibitors, such as rivaroxaban and apixaban. So these drugs on the right side of the screen, you will see that as a site of mechanism of action. So they inhibit, activate factor 10 and prevent thrombin generation. Also, as Dr. Yasser said earlier, the more action of them, especially on platelet as well. So it's not only as an anticoagulant, pure anticoagulant. Metabolism mainly in liver. So caution with cytochrome P3A4 inhibitors, which potentiate the action of these drugs. Elimination of the NOACs is mainly renal. About third of the drug it's excreted and changed in urine. Half-life is about 12 to 14 hours. So they are approved for usage in prophylaxis and treatment of venous thromboembolism and pulmonary embolism, and to prevent stroke in non-valvular atrial fibrillation. Rivaroxaban as well is used for prevention of thromboembolic events in case of patient with coronary or peripheral artery disease. Adnexonate alpha is licensed for reversal of apixaban or rivaroxaban, but in case of serious bleeding, still prothrombin complex and FFP can be used. It will help. So this is a comparison between the oral anticoagulants, comparing apixaban, rivaroxaban, edoxaban, and dabigatran. So mainly just to pay attention to the metabolism. You will find rivaroxaban is dependent on cytochrome B, about 30% on cytochrome metabolism. So it's very important to pay attention to drug-drug interaction in case of rivaroxaban. Apixaban less 15%. Half-life of the drug, apixaban about 8 to 15 hours, rivaroxaban 9 to 13 hours, edoxaban 10 to 14. To be honest, I didn't see edoxaban in clinical reality. I don't know if you have experience with it. Dabigatran is half-life about 12 to 14 hours. Renal elimination is dabigatran is the highest dependent on renal excretion, is about 80%. So it's very important to check renal function before prescribing it. Warfarin, we know the one of the oldest indication of anticoagulation is warfarin. Warfarin acts as anti-vitamin K, or it blocks the synthesis of vitamin K dependent clotting factors, factor 2, 7, 9, and 10. It mainly works to preventing the conversion of the vitamin K into oxidized form. So it will reduce the carboxyglutamyl residue that is required for active clotting factor 2, 7, 9, 10. So to produce its action, so it is not, warfarin will not affect the already formed coagulation factors, but it will affect the synthesis of the coagulation factors. So its action will be apparent at least about 72 hours to 96 hours. It is completely absorbed from gut. It is highly bound to plasma protein, about 95%. It's very important to understand if you are giving something to displace the warfarin from protein binding, so the drug will be, it will potentiate the action of the drug. It causes the placenta. Half-life about 40 hours, metabolized in liver with cytochrome P 450 into inactive metabolites, and excreted in urine and feces in inactive compounds. Monitoring mainly by INR, targeting INR 2 to 3 in most indication, but in some mechanical valves like mitral needs a higher 2.5 to 3.5 targeting INR. So warfarin is it's widely used for prevention and treatment of venous thromboembolism, such as DVT, deep venous thrombosis, and pulmonary embolism, and prevention of thromboembolism in atrial fibrillation, aromatic or prosthetic heart valves, antiphospholipid syndromes, and protein C and S deficiency. It also licensed to be used in prevention of venous thromboembolism in orthopedic and gynecological surgery. Despite we're not commonly using nowadays warfarin in those patients, but because we have alternative already. Adverse effects mainly hemorrhage, teratogenicity. It is not for a pregnant woman. Skin necrosis, purple toy syndrome, because it depends mainly due to spread of atheromatous plaque distally and cause bluish toys and like distal ischemia of toys. Drug interaction, it has very wide drug interaction. So metabolism dependent on cytochrome P 450. So there are lots of drugs can potentiate warfarin action and increase INR. So pay attention to drug interaction. Reversal of warfarin induced bleeding. It depends on how serious is the bleeding. So if it is life-threatening bleeding, we used to give prothrombin complex concentrate and vitamin K intravenously, and you give FFP. If there is just INR, but to correct INR, so we are moving toward giving vitamin K and omit warfarin dose, and reduce the following doses of warfarin, and careful monitoring for the INR. So just to summarize the mechanism of action of anticoagulants in this slide, I feel it's a brilliant slide for me because it summarizes the action of different drugs. You see heparin and fondaparinux and low molecular weight works through antithrombin 3. You see antithrombin 3, fondaparinux and low molecular weight works mainly on factor 10A. Heparin works and low molecular weight on factor 2A. You will see direct thrombin inhibitors, Rivaroxaban, Apixaban, and Edoxaban, and working on 10A and reversal andexanate alpha. You will see on the bottom of the right side the direct thrombin inhibitors working on thrombin and the reversal idaruximab. So, learning message. Choice of anticoagulant is multifactorial. It's not depending only the indication, but also you consider patient factors and you consider the comorbidities of the patient. And if the patient is taking drugs, I'm not talking only on giving anticoagulation within the critical care units, even discharging the patient on oral anticoagulation is something serious and need to pay attention to it. Unfractionated heparin is still widely used, and we follow protocols in different, each hospital has a protocol for those adjustments. Unfractionated heparin and low molecular weight heparin could cause heparin-induced thrombocytopenia. So in case if the patient at risk of HET, so fondaparinux and direct thrombin inhibitors, and some resources said also novel oral anticoagulant can be used.
Please, Dr. Ahmed, please.
Yes. It's time.
Please.
So actually, there is no question at the moment, and because of the time, Dr. Safa, I will ask Ahmed just one question, and you can go ahead for the next speaker. Okay, Ahmed?
Yes, sure.
Yeah, you mentioned about the heparin-induced thrombocytopenia.
Yes.
Okay. If a patient coming for surgery with this problem, whatever, he has bleeding secondary to thrombocytopenia, or he have, for example, intra-abdominal infection or fracture or whatever, how we can immediately manage this thrombocytopenia before coming the surgery or intraoperative? What is our role in this situation?
So I think it is not advised to give platelet at this stage because it will be increasing, it will be consumed. I'm not sure if it's it depends on the situation. About how low platelet is. If the patient has, like, for example, serious bleeding, do you mean serious bleeding, like intra-abdominal or intracerebral?
All right, okay.
So I'm not sure, to be honest, yeah.
Okay, Dr. Safa, you can go ahead. Turn on your speaker.
Thank you, Dr. Ahmed Issawi. Thank you. Great pleasure for you. Thank you. Dr. Wissam, are you ready? Or Dr. Mohammed Shurbagi? Dr. Wissam.
Hello, Dr. Safa, I will check.
Are you ready?
I will check to share my...
Can you rejoin?
Yes.
You can now?
Yes, Dr. Safa, I am ready.
Yes. Great pleasure to introduce you, Wissam. Go.
I would like to thank my professor, Dr. Safa and Dr. Saad, to give me this opportunity to share with you this tonight in this webinar. Thank you very much. Hello, my professor and my colleagues. We're going to talk about the physiology of coagulation and maybe giving a hint about coagulopathy. The objectives of our talk today, at the end, we should know what's the meaning of hemostasis, the steps of hemostasis, role of each component of hemostatic mechanisms, and what is the meaning of coagulopathy. First, we should ask a question. What is keeping our blood thin? Actually, we have three natural mechanisms. Number one, the intact endothelium release nitric oxide and prostacyclin I2. This inhibits the platelet adhesions. Number two, the heparin sulfate, which is secreted endogenously, which act with antithrombin 3 and making a complex, inhibits already factors 2, 9, and 10. The thrombomodulin thrombin complex, which activate the protein C, and active protein C in turn inhibits factor 5 and factor 8. These three natural mechanisms maintaining the fluidity of the blood. Then, what is the meaning of hemostasis? Hemo means blood, stasis, it means to stop. So it is a physiological mechanism, the process of blood clotting formation at the site of vessel injury. So once we have bleeding, the hemostatic response started as quick as possible to stop bleeding and prevent blood losses, and should be localized at the site of injury only to prevent the thromboembolic manifestations and be regulated by certain mechanisms. So we will go briefly, then we will start to talk in details. We have four components for the hemostatic process: the blood vessels, the platelet, the clotting factors, and the fibrinolytic system. The blood vessels start to vasospasm with the bleeding. Then after that, the platelet form the platelet plug, which help in stopping of the bleeding. Then after that, starting of the coagulation cascades, which is, as we know, the extrinsic and intrinsic pathways, ended with the common pathways, then ended by formation of fibrin and the clot. Then after that, the clot retraction mechanisms, then removal of the clot by the fibrinolytic system. This is in brief. So this is the four component, as we said, for the hemostatic response. What is the role of blood vessels? What is the mechanisms of blood vessels making it vasoconstrict in response to bleeding? We have three theories. Number one, the humoral theory, due to release of some mediators like endothelin, thromboxane A2, 5-hydroxytryptamine, and adrenaline. All these mediators act directly to vasoconstrict the blood vessels and help to stop the bleeding. We have another theory, the myogenic theory, which affect the smooth muscle of the wall of the blood vessels, making it to contract and vasoconstriction occur. And we have nervous mechanisms due to stimulation of nociceptors due to pain induced by the trauma or by the injury. The formation of platelet plug started with platelet adhesion, aggregations, secretions, and the procoagulant activity of the platelet. The platelet adhesions started by deposition of platelets in the subendothelial matrix and which bind with von Willebrand factors, which is a very important factors present in the endothelium. And once we have injury, endothelial injury, the von Willebrand factors become activated and attract the platelet to be bind with it at the site of injury. And after that, we have release of some mediators in the circulation, which aggregate the platelet to be deposited on the site of injury, and which secretes some, and the platelet also secretes some granules, which help in the formation of the platelet plug. And by the way, the platelet has a procoagulant activity, which already stimulate the clotting cascades by thrombin generation. So this diagram just showing how the platelet plug start to be formed at the site of injury by platelet adhesions and aggregation to the site of injury. What makes the platelet activated? We said before the three natural mechanisms making the platelet inactive form. But once we have injury, the platelets start to be activated by releasing of some mediators. These mediators like thrombin, collagen, ADP, epinephrine. ADP, by the way, this is the site of action of clopidogrel, one of the antiplatelet. Both of them are very strong activator, like the collagen and thrombin, and ADP, epinephrine, we consider it weak activators to the platelet. The platelet adhesion starting by morphological changes of its shape and make it extremely adhesive. And as we said, von Willebrand factors like or loves to bind with platelet, and the platelet is the same at the site of injury. So once the platelet start to has morphological changes, directly it transfer or bind to the site of injury with von Willebrand factors at a specific receptors. So each platelet has a specific receptors for von Willebrand factors. This has happened in the subendothelial matrix. And this receptor is called glycoprotein 1b. So glycoprotein 1b and von Willebrand factors both are very important in the platelet adhesions. Deficiency of each component, the glycoprotein 1b will lead to a syndrome which is Bernard-Soulier disease, and von Willebrand factors will be affected if we have deficiency in it, and it's bleeding disorders, and it has 4 subcategories under it. So von Willebrand factors, fibrinogen, and the glycoprotein 2b and 3a, these 3 components are very important in inducing platelet adhesions and aggregation. We will start from the right side of the screen, the von Willebrand factors, which bind directly to glycoprotein 1b receptors in the platelet wall. This activate or stimulate the platelet adhesions, and it has a role also in clot retraction later on. By the way, the platelet itself cannot bind directly to each other without the presence of fibrinogen. The fibrinogen has bivalent symmetrical, it is a bivalent symmetrical molecules and able to bind with 2 receptors on 2 platelets. So it has the ability to bind 2 platelets in the same time and cross-linking them to make strong platelet plug. These receptors, it is the one specific for the fibrinogen. So it is abundant on the platelet surface, has low affinity to fibrinogen under the normal circumstances. But once we have injury, it turns to high affinity to fibrinogen. So these 3 components has great influences in platelet adhesions and aggregation. This diagram will summarize this. So von Willebrand factors will start to bind with platelet through this receptors, glycoprotein 1b, and after that, some mediators will be released, ADP, thromboxane A2, 5-hydroxytryptamine, which increase the platelet aggregation to the site of injury. Platelet co-adhesions will be through the fibrinogen, which has 2 ends, and specifically bind to the glycoprotein 2b, 3a, and by the way, also this is the site of action of antiplatelet abiseximab. Then after that, the role of clotting cascade or clotting factors. We all know the intrinsic pathway and extrinsic pathway ended with the common pathway. By the way, the extrinsic pathway, it takes almost 30 seconds to be completed, and intrinsic pathway, it takes about 4 to 6 minutes to be completed. But this model, it was helpful in interpretation of some laboratory tests like prothrombin time and activated partial thrombin time. But it is actually inaccurate physiologically. So they have two things more to explain what's happening in the coagulation process. Number one, the thrombin generation. They are talking about thrombin generation. Number two, the multi-components complexes. So thrombin generations has 4 phases. Phase 1 starting by when tissue factors activate with activated factor 7, this combination activate factor 10 and starting to initiate or generate some thrombin, a little of thrombin. And thrombin and activated factor 11 has a feedback manner. This is starting, and this is the primary response to the bleeding. Then after that, the thrombin is starting to be more generated. This is phase 2 amplification with the aid of activated factor 5, 8, 11, and the platelet itself. Then propagation, more and more thrombin, and then after that, cessation of the thrombin generation. Then thrombin, if we consider the clotting factors, which are 12, it is like a football team, but 12 rather than 11. We consider the thrombin is the playmaker of the team, and the fibrin is the striker of the team. The multi-component complexes, they introduced that to explain the intrinsic and extrinsic pathways. They said that we have 3 procoagulant complexes and 1 anticoagulant complex. Each complex has enzyme, cofactor protein, and enzyme substrate. So this is a 3 procoagulant. The extrinsic 10As, this stand for factor 10, 10As, intrinsic 10As, prothrombinase, and protein C anticoagulant. After that, with the continuation of the coagulation cascade after activation of the factor 10, which combined with the platelet factor 5 converts 1 prothrombin to 1 thrombin, and thrombin converts fibrinogen to fibrin with the help of activated factor 13, which is stabilized and cross-links overlapping fibrin strands. And experimentally, they found that the mice lacking factor 13 forming 1/5 clot size in comparing to the normal one. So factor 13, which is calling the fibrin stabilizing factor, as we know. So what is the control mechanism of this process, and what is stopping the coagulation progress? Number 1, dilution of the procoagulant in the blood flow. Number 2, removal of the activated factors through the reticular endothelial system, especially in the liver. Number 3, control of the activated procoagulant and the platelets by natural antithrombotic pathways, as we mentioned before. And we have 2 endogenous pathways to inhibit the coagulation, which is tissue factor pathway inhibitor and C1 esterase inhibitor. The tissue factor pathway inhibitors, it circulates already in the plasma with a very low concentrations and directly inhibits factor 10 and inhibits tissue factor and aggravated factor 7. The C1 esterase inhibitor, it is a member of the serine protease inhibitor sensitized in the liver and inhibits activated factor 7. What else controlling the termination of coagulation? The serine protease inhibitors. The antithrombin 3, as we said before, the clotting initiated inhibitory process, the protein C pathways, in addition to prostacyclin, thromboxane A2, and nitric oxide. Then the role of the fibrinolytic system. It is activated to restore the vessel patency following hemostasis and to prevent the extension of the clotting. The clot must be organized and removed by the proteolytic enzymes plasmin in conjunction with wound healing, and tissue remodeling. The plasminogen activated by the tissue plasminogen activator first, and turn it to fibrin. Binds to fibrin and activates plasminogen to plasmin. Plasmin cleaves polymerized fibrin strands and release fibrin degradation products and D-dimers, and cleaves also fibrinogen and a variety of plasma protein and clotting factors. So this is a physiological process. So what is the pathology regarding this process? If we have a pathology, so we have a coagulopathy. Coagulopathy, it means we have excess bleeding or thrombosis. It is happened with element, either with element missing or element dysfunction. So if we have element missing or element dysfunction, it will lead to either bleeding or thrombosis. So we have now coagulopathy. So if we just reviewing the causes of coagulopathy regarding each component, so regarding the blood vessels, we have vitamin C deficiency, this curvy, hemorrhagic telangiectasia, Ehlers-Danlos syndrome, which is a connective tissue disease affecting the blood vessels and leads to bleeding. If we refer to the platelet dysfunction, we have thrombocytopenic purpura, as mentioned with Dr. Sawi, Bernard-Soulier, which is deficiency or mutation in the receptors glycoprotein 1B. It leads to morphological changes and leads to macrothrombocytopenia. And we have Glanzmann thromboathenia and platelet storage ball disorders, no granules which secreted in the blood, and thrombocytosis, which leads to thrombotic manifestations. The clotting factors disorders, either bleeding or thrombosis, any deficiency in one of the clotting factors will lead to bleeding. And we have the thrombotic manifestations with protein C deficiency, protein S deficiency, and antiphospholipid syndrome. We have another general disorders like liver diseases affecting the clotting factors synthesis, like the vitamin K and the others. Where infectious disease may affect the bleeding disorders, excessive blood transfusion, trauma, and disseminated intravascular coagulopathy. At the end, we have another question. Where is factor 6 in this process? Is there a factor 6 in this process? Thank you.
Thank you, Sam. Thank you.
Thank you, Dr. Safa.
Thank you. I'm very sorry about my camera off because of technical problem. My camera is off because of technical problem. I'm sorry. I'm sorry.
Actually, there is no question. So I think, Dr. Safa, you can go ahead for the next speaker.
Okay, okay. Now I will introduce Dr. Mohammed Shourbagi.
Yeah. Stop sharing, Osam, please.
Okay.
Stop sharing your, please, Wissam.
Okay.
Yeah, okay, it's fine, yeah. You can share your slide, Muhammad.
Okay, okay. Dr. Mohammed Shourbagi. Dr. Mohammed Shourbagi. Egyptian, had MD in anesthesia from Ain Shams, in master degree in 2006 and doctorate degree Ain Shams University in 2011. He works in Ain Shams University in the Academy of Cardiothoracic Surgery and Nasser Institute for Research of Cardiothoracic Surgery, one of the eminent anesthesiologists for cardiothoracic anesthesia. Okay, Muhammad.
Thanks, Dr.
Okay,
Safa.
Muhammad.
Thanks, Dr. Safa. Thanks, Dr. Yasser. Thanks, Dr. Saad. Thanks all attending my presentation, my lecture about coagulopathy in cardiac surgery. Coagulopathy in cardiac surgery. My contents, learning objectives about physiology of coagulation and anticoagulation, coagulopathy in cardiac surgery, point of care coagulation monitoring, and mediastinal bleeding cardiac tamponade. As Dr. Wissam said about physiology of coagulation and anticoagulation, primary hemostasis, vascular endothelium platelets, secondary hemostasis involving coagulation cascade glycoproteins. So components of hemostasis include vascular constriction, formation of platelet plug, coagulation cascade, and then modulators of coagulation and fibrinolysis. Then again in this figure, component of hemostasis, vascular constriction, and platelet activation forming primary hemostasis, then coagulation cascades, prothrombin, thrombin, fibrinogen, fibrin to form what's called platelet blood clot, starting then antithrombotic control mechanisms as fibrinolysis and clot degradation or clot lysis. About platelet blood formation, it's formed of platelet adhesion, Willebrand factor, then platelet aggregation, ADP and thromboxane A2 release, then at least at end fibrinogen forming fibrin strands that make the final pathway of clot formation. This is the classic model of coagulation cascade, intrinsic, extrinsic, and final common pathway at factor 10, then prothrombin, thrombin, fibrinogen, fibrin to form firm cross-linked fibrin clots. While the new cell-based model, as Dr. Wissam said, initiation, amplification, propagation, and cessation to form what's called thrombin bursts or excess thrombin that convert fibrinogen to fibrin. Then we study modulators of coagulation, as activation of coagulation cascade triggers several physiological pathways that tends to counteract and limit the spread of coagulation to the area of injury, like endothelial surface factors, removal of some activated factors from the circulation by the liver, and the most important, the interaction between the platelet aggregatory effect of thromboxane A2 and the anti-aggregatory effect of prostacyclin that make clot forms as the site only of blood vessel injury, keep the vessel lumen free from clot. Then tissue factor pathway inhibitor, antithrombin 3 is important for our lecture. It binds to the serine protease in the coagulation system, blocking their activity as thrombin, factor 10, and factor 11. Thrombomodulin that make with thrombin, thrombomodulin thrombin complex that will activate plasma protein C and protein S that acts as anticoagulant against factor 5 and factor 8. And this figure will advise to us the modulators of coagulation and fibrinolysis, fibrinolytic pathway that make clot lysis. Also, we can revise and understand about the fibrinolytic pathway and fibrinolysis because our cardiopulmonary bypass will trigger hyperfibrinolysis, making more coagulopathy, as we say now. What are the pathophysiology of coagulopathy in cardiac surgery? What are the causes of coagulopathy in cardiac surgery? We have 4 causes of coagulopathy in cardiac surgery. The general cause of preoperative risk factors as patients on antiplatelets or anticoagulants, coagulation factor deficiency, liver or renal disease. Liver disease may cause coagulation factor deficiency or dysfunction, and renal disease may cause what's called thrombocythemia. Type of surgery is important. Emergency surgery has no time to stop antiplatelet anticoagulants. Complex surgery, prolonged surgical procedure, prolonged cardiopulmonary bypass time, trigger coagulopathy. Also redo cardiac surgeries with extensive adhesions, extensive dissection, bleeding, and dissemination for coagulopathy. About effects of cardiopulmonary bypass, we have 4 factors: platelet dysfunction, coagulation factor dysfunction, then hypothermia and hyperfibrinolysis. So we have 2 dysfunction, platelet and coagulation factor dysfunction. Platelet dysfunction from hemodilution of the cardiopulmonary bypass, heparin, hypothermia, and platelet activation with degranulation make it more weak when enter again the circulation. About cell salvage devices, reinfused products from cell salvage devices are deficient in platelets and coagulation factors, but rich in RBCs and hemoglobin. But we can allow platelet sequestration prior to cardiopulmonary bypass in an optimal option to preserve platelet from destruction and dysfunction before cardiopulmonary bypass. We have also an option of intra or acute acute normovolemic hemodilution. We can draw patient blood from the patient before cardiopulmonary bypass as a good source of RBCs and platelets. About coagulation factor dysfunction due to hemodilution, hypothermia, also use of bubble oxygenator and cardiotomy suction make trauma to coagulation factor. The most important hypothermia that can cause all the following about platelet and coagulation factor dysfunction: hypothermia-induced fibrinolysis. The splanchnic circulation responds to hypothermia with platelet sequestration. Also, hyperfibrinolysis can occur due to hypothermia with increased level of plasminogen activators and complement system. So we can try to allow usage of antifibrinolytics in cardiac surgery to prevent coagulopathy. So about heparin and the protamine pharmacology, we have multiple adverse effects of heparin use in cardiac surgery or cardiac anesthesia, like heparin resistance, heparin rebound, heparin-induced thrombocytopenia, and protamine excess. About heparin resistance, it may not causing coagulopathy, but we can revise what mean by heparin resistance. Heparin resistance means failed heparin to elevate activity clotting time or failure of heparin to causing optimal anticoagulation due to congenital or acquired deficiency of antithrombin 3. So about the other items, heparin rebound, heparin-induced thrombocytopenia, and the protamine excess, all these can cause medical bleeding in cardiac surgery. What means of heparin rebound? It means rebleeding from excess heparin entering the circulation after protamine neutralization that was sequestrated in fat reappeared again in circulation, causing what's called medical bleeding. Heparin-induced thrombocytopenia will be discussed later. Then protamine excess, that protamine may be causing anti-platelet dysfunction or platelet dysfunction in the circulation. I will run now in heparin-induced thrombocytopenia. Dr. Ahmed discussed it before. Immune adverse effect of heparin result in involvement of IgG antibody against heparin platelet factor 4, leading to thrombocytopenia, but it may cause also what's called the HIT, H-I-T-T, heparin-induced thrombocytopenia and thrombosis. This is the pathophysiology of HIT illustrated in this figure. Heparin, platelet factor 4, complex, IgG triggering and release, then activating platelet clot formation, thrombocytopenia, and may cause thrombosis. About diagnosis, we have 3 items: thrombocytopenia and extent of thrombocytopenia by quiet drop of platelet count by a factor of 30 to 50%, and investigation HIT antibody assay or titer. And this is the 4T scoring system for evaluating the pretest probability of heparin-induced thrombocytopenia as acute thrombocytopenia, timing of onset, thrombosis, other causes of thrombocytopenia, to give total score. If the score is low, no need for investigation, while high or intermediate risk groups should be treated as HIT until proven otherwise. Now about management of the cardiac surgical patient with HIT. The urgency of the surgical procedure is an important factor that can affect decision-making It is preferable, when possible, to defer the operation until antibody titers have become undetectable or only weakly positive, which may occur after 90 days. If surgical postponement is not practical, then other therapeutic options must be considered. Currently, the direct thrombin inhibitors are used as the anticoagulants of choice. Herodine, argatropone are approved by the US Food and Drug Administration for use in patients with HIT-related thrombosis. The use of these drugs as anticoagulants for cardiopulmonary bypass carry the risk of hemorrhagic complication, while bivamelagon has been approved by the FDA for use in percutaneous intervention, and because of its short half-life, has been favored as an anticoagulant for cardiopulmonary bypass in patients with HIT. These are alternatives to heparin, and we will choose the category of direct thrombin inhibitors as herodine, bivamelagon, and argatropane as alternative to heparin before cardiopulmonary bypass. The most appropriate is bivamelagon, while, however, no drug other than heparin has FDA approval for specific use as anticoagulants in patients undergoing cardiopulmonary bypass. Bivamelagon undergoes renal elimination. Therefore, in seropositive HIT patients who have significant renal dysfunction, anticoagulant for urgent operation requiring cardiopulmonary bypass can be accomplished with argatropane and plasmapheresis prior to heparin to remove antibodies, or heparin with concomitant antiplatelet agent to prevent platelet activation, like tirofiban and iloprost. But these later two techniques have risk because they include heparin and have been fraught with increased risks of bleeding. The last item of coagulopathy during cardiac surgery are medical coagulopathy, like hypothermia, abnormal temperature, acidosis, abnormal pH, because normal pH and normal temperature are essential for the function of clotting factors and platelets. Hypocalcemia as calcium as one of the clotting factors, anemia because hemoglobin and fibrinogen may entangle RBC's clot formation. The most important are the point-of-care coagulation monitoring devices. Coagulation monitoring in the surgical patient has focused on preoperative testing to identify patients at increased risk for perioperative bleeding and intraoperative monitoring of heparin therapy during cardiac and vascular surgery. While more recently, availability of increasingly sensitive and specific point-of-care coagulation monitors has provided an opportunity to guide administration of blood component therapy and hemostatic drugs more specifically, without the delays inherent in the standard laboratory testing like thromboelastography and sonoclot tests. We use activity clotting time in our cardiac surgeries, as the normal AST in normal individuals before heparin is approximately 107 seconds. When we use cardiopulmonary bypass and need optimal anticoagulation, prolongation of the AST to greater than 480 seconds is usually deemed adequate. While in off-pump CABG procedures, sometimes use partial heparinization with an AST target of about 300 seconds to allow mammary harvesting with no clotting inside the mammary artery. They are the clinical variables that can affect the activated clotting time, as hemodilution, hypothermia, thrombocytopenia. Abrotinine has removed from the market 10 years ago. We can say that hemodilution and hypothermia may cause false prolongation of activated clotting time at cardiopulmonary bypass. About thromboelastography, the unique aspect of viscoelastic measures lies in their ability to measure the entire spectrum of clot formation, from early fibrin strand generation through clot retraction and eventual fibrinolysis. EEG provides unique advantages over AST and traditional coagulation parameters because it provides functional information on platelets, clotting factors, and fibrinolytic processes. So we can say that the TEG may be used to differentiate surgical bleeding from coagulopathy following cardiac surgery. We can differentiate surgical bleeding from medical bleeding to decide the choice of reopening the patient again for surgery. About TEG parameters, reaction time R value, time to initial clot formation, what's called initial clot time. It is considered comparable to the whole blood clotting time, can be accelerated by adding Clide to the TEG sample cuvette. R value is prolonged mainly due to deficiency of one or more plasma coagulation factor. So in patients with prolonged reaction time, it means suspicious for coagulation factor deficiency for fresh frozen plasma administration. Maximum amplitude, it is a measure of clot strength and may be decreased due to either platelet dysfunction, qualitative or quantitative, or decreased fibrinogen concentration. Alpha angle and coagulation constant values, it measures the rate of clot formation. It may be slowed due to deficiency in coagulation factors or maybe due to heparin excess. And this is the normal TEG trace, normal thromboelastogram, starting from initiation, platelet blood formation, then the clot grows, reaching maximum clot formation, maximum amplitude, then fibrinolytic pathway or excess fibrinolytic activity causing at end a clot dissolution or clot dissolvent. These are the abnormal TEG trace that can help us to know the cause of coagulopathy after cardiopulmonary bypass or during cardiac surgery in general. We concentrate in the hemorrhagic section, either low clotting factor function with prolonged reaction time, low platelet function with prolonged maximum amplitude, low fibrinogen level, and the most important, the fibrinolytic issue of fibrinolytic pathology, what's called tear drop appearance of thromboelastogram. Also, we have what's called platelet function analyzer or point of care platelet function analyzer. Platelet mapping, like sonoclot tests, can assess platelet function or thrombocythemia even with normal platelet count as renal impairment or von Willebrand deficiency. Also can provide adequate surgical timing for patients on antiplatelet treatment, more accurate than knowing the T-half or pharmacokinetics of antiplatelet medications. The last section in my lecture about mediastinal bleeding and cardiac tamponade. Mediastinal bleeding, one of the most frequently reported complications of cardiac operation. It increases the risks of cardiac failure, dysrhythmias, and infection and mortality. Appropriate treatment requires a rapid and effective diagnostic workup based on the knowledge of the pathophysiology induced by the cardiopulmonary bypass and the surgical trauma or surgical bleeding. There are many sites for surgical trauma or bleeding. We can conclude that among those sites, the most frequent source of hemorrhage are the venous and arterial anastomosis for CABG surgery, mammary bed after mammary harvesting, cannulation site for cardiopulmonary bypass as aortic cannula and venous cannula, and the sternum. Okay, we must diagnose mediastinal bleeding. Bleeding after a cardiac operation is generally considered to be abnormal when it exceeds 500 to 300 ml per hour for the first 2 hours, or 100 to 150 ml per hour thereafter. Bleeding in excess of these volumes usually requires immediate surgical intervention to avoid tamponade or hemorrhagic shock. A decision must be made as to whether or not an indication exists for surgical exploration as opposed to medical correction of a bleeding diathesis or a medical bleeding. Another scenario, when drainage of blood is minimal, the diagnosis of mediastinal bleeding is more difficult. When drains is occluded, in this case, active bleeding may be present by the patient without being exteriorized. The drainage system may be occluded by clots or adhesions, isolating the bleeding site. Also, hemorrhage from non-drained space as pleural cavity will be hidden. So, early evacuation is important to avoid dramatic consequences of tamponading due to occluded drainage system. Allow early detection by frequent measurements of the right and left-sided filling pressures as CVB and pulmonary capillary wedge pressure, and of the cardiac output to suggest the correct diagnosis. So, patient with low cardiac output, low blood pressure, combined with low filling pressures, the most commonly used CVB, low blood pressure, low cardiac output with low CVB, low filling pressure, imply a significant volume depletion. While on the other hand, an increase in the right side filling pressure, increased CVB, congested neck veins with low cardiac output suggests pericardial tamponading. Echo can be useful to confirm diagnosis, but also take care that it may be RV failure. Patients with RV failure, we may have elevated right side filling pressure with low cardiac output. Preventive measures, prophylactic antifibrinolytics as a general medication used in all surgeries, cardiac surgeries, meticulous surgical hemostasis, short cardiopulmonary bypass, or even avoided as in off-pump cardiac surgery, maintenance of body temperature and pH all through the cardiac surgery and in ICU, close monitoring of post-operative hypertension to avoid bleeding. Treatment protocol for excessive mediastinal bleeding after cardiopulmonary bypass in adults. In very minimal bleeding with stable hemodynamics, no treatment. While in bleeding as 50 to 150 ml per hour, we will search for hypothermia to correct body temperature. Search for hypertension to normalize blood pressure. For diffuse oozing suspected, cardiac surgeon may give us a trial of PEEP when the patient on mechanical ventilation to tamponade the diffuse oozing. But respect that PEEP may cause severe hypotension from decreased cardiac output and venous return. We can search about the cause of coagulopathy. As in heparin excess, we can give protamine. When we can say elevated BT and AST, factor deficiency with elevated BT, we can give fresh frozen plasma. In patients with thrombocytopenia with low platelet count, we can give platelet concentrate. In patients with platelet dysfunction, with renal impairment, normal platelet count, but prolonged bleeding time, we can give desmopressin that stimulate release of vulnerable factor from endothelium, but respect tachyphylaxis. Fibrinolysis with elevated FDPs, D-dimer, and TEG characteristic form of teardrop evidence of fibrinolysis. We can give tranexamic acid, epsilon aminocaproic acid. And in case of massive bleeding, excessive bleeding, arterial bleeding, tamponade by clinical suspicion or by echographic findings, we must allow immediate surgical re-exploration and Novo-7 administration.
1 minute before more, please, Dr. Muhammad, because the time is over.
Yes, okay. About Novo-7 risk benefit, factor 7 act locally at the site of vessel injury by binding tissue factor on subendothelial cells and facilitate transformation of active factor 10 and 9 to active forms. What's called resulting in a thrombin burst. We can use it in thrombocytopenic patients. Novo-7 is effective in reducing bleeding and decreased RBC component therapy requirements instead of refractory bleeding as a last choice. However, reported complication rates associated with factor 7 use as thrombosis. They also found that drug may be more effective if given early in the course of bleeding after correction of identifiable coagulation defects as pH, temperature, fibrinogen level. The half-life of factor 7 is only 2 to 12 hours, so we respect repeating the dose until the bleeding is controlled. In a comprehensive evaluation of label use of factor 7 in Canada, they found that factor 7 administration median dose of approximately 60 mic per kg was associated with significant reduction in transfusion without increase in death or major morbid events as thrombosis. My take-home message: a decision must be made as to whether or not an indication exists for surgical exploration as opposed to medical correction of coagulopathy only. Thank you.
Thank you so much, Dr. Muhammad Ash-Shorbagy. And actually, we don't have questions. Just I will, because of the time, I will just ask you one question. What is the common coagulation abnormalities in cardiac surgery? Thrombocytopenia, hypofibronegenemia, what is the most common?
We say that it is multifactorial, especially in the patient with high risk. The patient with high risk of coagulopathy, old age with prolonged cardiac bypass time, we have mainly thrombocytopenia with hyperfibrinolysis. We give the patient a high dose of antifibrinolytic before and after cardiopulmonary bypass, like 2 gram anti-cyclocapran. Then we respect to add fresh frozen plasma or platelet concentrate in suspected oozing.
All right. Is it common to use platelet transfusion during cardiac surgery or occasionally?
Occasionally, but we respect the initial platelet count before cardiac surgery. If his platelet count is borderline, like 150, we can add platelet concentrate after cardiopulmonary bypass and after closure of the wound.
You give tranexamic acid prophylactically or no? Or
we give tranexamic acid prophylactic in all cardiac surgical patients, adult, before surgical stimulation or before surgical incision. We give about approximately 2 gram cyclocapran in 80 kilogram adults. Then we give again 2 gram cyclocapran after cardiopulmonary bypass.
Okay, thank you so much, Dr. Muhammad Ash-Shorbagy, and we can go ahead. Dr. Safa, you can go ahead for the next speaker, please.
Okay. I'd like, I'm great honor to introduce Prof. Dr. Anirban. He is an Indian. Really, Indian Valley civilization flourished between 2800 BC and 1800 BC, had an advanced and flourished economic system. The Indus Valley people practiced agriculture, domesticated animals, made tools and weapons from copper, bronze, and tin, and even traded with some Middle East countries. And India are ancient civilized countries. Salute Egypt, salute India. Prof. Dr. Anirban Chaudhary is a director professor of anesthesia and critical care, GP Pant Hospital, New Delhi. Area of interest is mechanical ventilation, sepsis, expert committee member of National Medical Commission, National Board of Examination New Delhi, AIMS New Delhi, Institute of Liver and Biliary Science New Delhi, DCGI New Delhi, and UGC New Delhi. This is the hospital where Dr. Chaudhary worked. Yes, okay, Prof. Chaudhary, okay. Okay.
Thank you, Dr. Hilal, for the kind words. At the very onset, I wish to thank the Egyptian Society of Anaesthesiology and also the organizers of this virtual online program for organizing this wonderful mega online course. And also I thank for giving you an opportunity to present in this platform. I bring to you my greetings from India, and I hope that you have a very fruitful session. Now, my job has been made easier by my previous speakers who have mostly covered the important areas of anticoagulation management, including the perioperative period beginning from the first speaker. So what I will be telling is certainly will be an overlapping, but it will be a more of a recapitulation rather than something new. So while talking about perioperative management of anticoagulation, let us start with a case. Our patient is a 54-year-old male, a case of subacute intestinal obstruction with signs of peritonealism in the form of rebound tenderness. The patient has history of myocardial infarction 3 months ago and was placed a drug-eluting stent PCI in the LAD. Patient also gives a history of stroke, an acute ischemic stroke 1 year ago. And presently, the patient is on dual antiplatelet, aspirin clopidogrel, on telmisartan, metoprolol, rosuvastatin, and dabigatran. The CECT abdomen shows adhesions and narrowing in the jejunum, along with some free fluid also in the peritoneum. The patient has been planned exploratory laparotomy for this condition. So the question remains, what should be the coagulation management during the perioperative period of this patient or in such similar patients? Now, any approach on the perioperative coagulation management is based upon 4 considerations. And if we consider this serially, we won't miss anything. Number 1, the risk stratification of patient-related and procedure-related risks of thrombosis and bleeding. Because we know that certain patients are at higher risk of thrombosis than others, and certain patients are at higher risk of bleeding than others. And also some procedures can cause an accelerated thrombosis, some procedures can lead to excessive bleeding. So that risk stratification is very vital. Second, the clinical consequences of a thrombotic or a bleeding event. The bleeding event can occur inside a closed space, it can occur outside a closed space. If there is a bleeding event inside a cranial cavity, in the mediastinum, or else in some areas where the consequences can be more harmful, then that should strike an alert note much before, because that cannot be tolerated by the patient. Third is the plan of discontinuation or reinitiation of anticoagulation therapy based on the pharmacokinetics of the agent that are being used. And fourth, the decision about the use of periprocedural heparin bridging for the prevention of postoperative thromboembolism. So based upon these 4 considerations, our road forward can be decided upon. Now coming to the first point, that how to suggest risk stratification for perioperative thromboembolism. Now this is the American College of Chest Physician guidelines. They have identified 3 major conditions where the risk of perioperative thromboembolism is very high. There can be others where also the risk of thromboembolism may be high, but these 3 in particular have been notorious. One is the presence of mechanical heart valve, second is atrial fibrillation, and third is a patient who already has venous thromboembolism, either in the recent past or before. Now, these are categorized into high, moderate, and low based upon whether the risk is more than 10% per year of arterial thromboembolism or more than 10% per month of venous thromboembolism, or 4 to 10% of arterial and 4 to 10% per month of venous, or less than 4% per year of arterial and less than 2% per month of venous. And accordingly, there are set criteria which have been identified that comes under the high, moderate, and low category. For example, if there is a bileaflet AVR without major risk factors for stroke, that is of low risk. If there is a bileaflet AVR with major risk factors for stroke, it is moderate. But any mechanical mitral valve, caged valve, or tilting disc valve in mitral or aortic position and a recent stroke or TIA within 6 months puts the patient at high risk category. Similarly, the CHAD score of more than 5 or 6, along with a recent stroke or TIA, presence of rheumatic valvular heart disease puts them at high risk of thromboembolism following atrial fibrillation. A CHAD score of 3 or 4 puts them in moderate, while a score of 0 to 2 and no prior history of stroke or TIA puts them under low risk. And likewise, for venous thromboembolism, if the history is of more than 12 months, it is low. If it is within past 3 to 12 months with recurrent VTE, non-severe thrombophilia, active cancer, the risk is moderate. And for rest of the conditions, again, it falls under the high risk category. Now, one thing needs to be mentioned about this CHAD score for the simple reason that This indicates the increased risk of thromboembolism in patients with atrial fibrillation. Now, previously we used to have this CHADS-2 score. It is still being used, considerably good. But now we also have another score, which is the CHADS-2 VASC score, which additionally includes 3 more parameters, that is the presence of vascular disease, age 65 to 74, and female sex category, which were not there in the CHADS-2 score. And it gives a more points, that is a point of 2 is given to age over 75 years instead of 1, and age 65 to 74 also gets a point. So now it is seen that this CHADS-2 VASC score markedly improves the classification and can identify the patients who are truly at risk of stroke, maybe sometimes better than those than that of the CHADS-2 score. Now, next comes that then how to determine the risk of bleeding. Now, this acronym gives some relevance in this field, that when a patient is undergoing surgery, the presence of any of these factors, if present, falls under, like H stands for hypertension, A for abnormal liver and renal function. If both are abnormal, the score is 2. If either of them is, the score is 1. Then stroke, bleeding, labile INR, elderly more than 65, and drugs or alcohol. Again, the point is 1 or 2, depending upon whether one factor is present or both are present. And a Hasbled score of more than 3 indicates a high bleeding risk. So along with that, there are also certain procedures which are of high surgical procedures which has high risk of bleeding, like colonic polyp resection, ERCP, sphincterotomy, cardiac surgery, intracranial surgery, spinal surgery, major orthopedic surgery, so on, along with some surgeries which have comparatively lesser risk of bleeding as indicated in the table below. So therefore, among the surgical procedures, if the person is supposed to undergo intracranial, cardiac, and neuroaxial procedures, they are of particular concern for the reason that I stated before, because here the blood accumulates inside a closed cavity, so the risk of herniation in case of brain, risk of epidural hematoma in case of spinal cord, risk of tamponade in case of mediastinal bleeding. So all this is considerably higher and can be lethal. So now how to determine whether or not to interrupt the anticoagulation therapy? Now the optimal management is only achieved through a balance between this thromboembolic and bleeding risk. And all I say is that however scoring system may be accurate, however charts and guidelines may be followed, it is not possible to identify absolutely at a target 0 level to a patient with equal dexterity that the risk of thromboembolism is, or bleeding perfectly. So always there has to be a balanced decision based on the presence or absence of these factors on a case-to-case basis. Patients with a high risk of bleeding will benefit from anticoagulation interruption. Patients with high risk of thromboembolism may benefit from a bridging therapy and the shortest period of anticoagulation withdrawal. So now how to plan surgery in a patient with dual antiplatelets? Because many patients who have been undergone percutaneous coronary intervention are on dual platelets, most of them, because drug-eluting stents are commonly placed nowadays everywhere. So if aspirin and pyridine need to be withheld during the perioperative period for high risk of bleeding, then elective surgical procedure should be delayed 6 weeks for patients with bare metal stent and for 6 months for patients with drug-eluting stent. In case the surgery cannot be postponed for that time, the dual antiplatelet therapy should be continued throughout the perioperative period. Now, this 2016 American Heart Association and American Cardiology Association guidelines updated and modified the previous recommendation, which used to be 1 year for DES and 6 months for bare metal stent. So this has been modified and revised. However, if we look into this large systematic review, we can very well see which seeks to look into the studies that have investigated the effect of platelets. We find that evidence regarding perioperative antiplatelet management in patients with cardiac stents undergoing non-cardiac surgery is insufficient to guide practice. Why so? Because here you can see this is the bleeding risk. This is the most severe and adverse cardiovascular event risk. Here it is less than 6 months, here it is more than 12 months, and here it is 6 to 12. So this blue indicates bridge therapy. That increases again the risk of the bleeding event rate increases. although the adverse cardiovascular events rate is minimized. Whereas this DF, that is double antiplatelet, if it is continued both, that reduces the risk of bleeding, but again, the adverse cardiovascular is not changed, but the risk of bleeding is reduced. So there are a lot of fallacies in the studies which this meta-analysis revealed. And therefore, it cannot be said with confirmation that what would be the best approach in such cases. Then how to manage antithrombotic therapy in patients undergoing surgery? Based upon the studies and guidelines, patients with recent coronary stent implantation should postpone elective surgery during the critical periods, which I mentioned, 6 weeks for BMS and 6 months for DES. If surgery cannot be postponed, dual antithrombotic therapy should be continued throughout the perioperative period. In patients who are at high risk of cardiac events, aspirin should be continued throughout the perioperative period, with clopidogrel and prasugrel discontinued 5 days prior to surgery and resumed 24 hours postoperatively. For patients at low risk of cardiac events, then there again, dual antiplatelet therapy can be discontinued 7 to 10 days before surgery and restarted 24 hours postoperatively. So this is not a guideline, but it is an advisory, so that can be implemented as per the prevailing practice guidelines of a place, of an institute. Next question comes, then what is this bridging therapy? Bridging therapy is nothing. Bridging anticoagulation consists of substitution of a long-acting anticoagulant, usually which we call is warfarin, for a shorter acting coagulant, usually the low molecular weight heparin. So this limits the time of subtherapeutic anticoagulation levels. So therefore, this risk of thromboembolism is minimized. And in special cases, this bridging therapy may be used. So when to bridge? When a patient is having a mechanical heart valve following MVR, DVR with additional risk factors like stroke, TIA, cardioembolic events, intracardiac thrombus, more than 2 mechanical valves, etc. Patient with stroke, episodes of systemic emboli or VTE during the last 3 months, patients with atrial fibrillation and CHAS2 VAS score of more than 5, along with additional cardiovascular risk factors, and patient with recent coronary stenting within the past 12 weeks. So this was the original bridge study design, in which this study, which 1884 patients were enrolled, 950 were assigned to receive no bridging therapy, 994 were assigned to receive bridging therapy, and incidentally, this found that the incidence of arterial thromboembolism in the no bridging group and the bridging group did not differ, because it was 0.4% versus 0.3%, which was not significant. But the incidence of major bleeding, which occurred, that was 1.3% in the no bridging group and 3.2% in the bridging group. So therefore, the bridging group had more bleeding. So what they did in this study was that they stopped here. They stopped warfarin. Here, 3 days before they started this, they started the study drug. Here you can see around 3 days before the surgery, and the placebo in another group. And later on, within 1 day, within 24 hours, they restarted either dalteparin, which was the study drug, versus the placebo. And then once the INR was reduced to normal, then they restarted the warfarin. So they resumed dalteparin or placebo within 24 hours after the procedure in patients who underwent a procedure associated with low risk of bleeding, but they resumed dalteparin or placebo 48 to 72 hours after the procedure in patients who underwent a procedure with a high risk of bleeding. So later on, they stopped when the study drug, when the INR therapeutic was achieved, they continued with warfarin. Now, if we see, this is the study which did not show any difference in benefit, but still then there were a lot of studies which compared this bridging versus no bridging in different cohorts of patients, and also the times varied. Some were prospective, some were retrospective, some were RCTs, as well as there were meta-analysis too. So despite the growing evidence about limited to non-existent benefits of bridging therapy, yet it is still being used as on a case-to-case basis, because it is considered to be useful in some patients. So how to bridge? As I said, preoperatively discontinue warfarin 5 days before the surgery. 3 days before the surgery, start with subcutaneous low molecular weight heparin or unfractionated heparin, depending upon the renal function of the patient at therapeutic doses. 2 days before the surgery, assess the INR. If the INR is greater than 1.5, vitamin K can be administered at a dose of 1 to 2 mg, and then discontinue low molecular weight heparin 24 hours before surgery or 4 to 6 hours before the surgery if unfractionated heparin is used instead of low molecular weight. In the post-operative period, if the patient is tolerating oral intake and there is no unexpected surgical issues that would increase bleeding risk, restart warfarin 12 to 24 hours after surgery. If the patient received preoperative bridging therapy, that is high thromboembolic risk, and underwent a minor surgical procedure, resume low molecular weight or unfractionated heparin 24 hours after surgery. If the patient underwent a major surgical procedure, then it's say around 48 to 74 hours after surgery. But it is important to always assess the bleeding risk and adequacy of homeostasis before resumption of the low molecular weight heparin or unfractionated heparin. Again, it is to be important that the guidelines of the thoracic ATS along with the ASRA 2018 guidelines, that is similar to the American College of Guidelines also. So there is no difference, although the evidence is limited, but the guidelines on the use of bridging therapy is similar between the surgeons and the physicians. So how to manage patients on DOS, the newer oral anticoagulant therapy undergoing surgery? We have to remember that bridging therapy is not indicated in patients on DOACs. Timed interruption of anticoagulation therapy before surgery is essential, and the appropriate timing of interruption of the DOAC is based on the invasiveness of the procedure that the patient is undergoing and the bleeding risk of the procedure, the pharmacokinetic profile of the drug, which has also already been covered in some of the lectures previously, and also on the clinical characteristics of the patients like renal function and the liver function. It is to be remembered that as a principle, DOACs should be held 3 half-life times before low-risk procedures and 5 half-life times before high-risk procedure as a principle. So this discontinuation, if the patient is either on this rivaroxaban, apixaban or edoxaban, if the bleeding risk is low, stop 1 day before. If the bleeding risk is high, stop 2 days before the surgery or the procedure. In case of dabigatran, if it is low, we check the creatinine clearance. If it is more than 50, stop 1 day before. If it is less than 50, stop 2 days before. If the bleeding risk is high and the creatinine clearance is more than 50, then stop 2 days before. And if it is less than 50, then stop at least 4 days before. So this is in rough the approach in discontinuation of the DOAC. However, it is also important that timing of DOAC resumption after surgery is also important. So in patients with low bleeding risk, restart anticoagulation 6 to 8 hours after surgery. In high bleeding risk, restart anticoagulation 48 to 62 hours after surgery. Now, how to perform an emergency reversal of anticoagulation? We have to remember that sometimes 2 scenarios may occur. An urgent procedure. Urgent procedure is defined as one where the procedure can be delayed up to a maximum of 24 hours, giving some time to the physician to conduct anticoagulation reversal based on repeated coagulation tests. Another scenario can be emergent scenario, which is defined as one in which the patient requires surgical intervention in less than 1 hour or is experiencing life-threatening bleeding. In emergent scenarios, the amount of time, the number of coagulation tests that can be performed, and the opportunities that are available to the physician to delay the procedure till are very limited. So accordingly, we have to go for it. In cases of warfarin, if it is a non-significant bleeding with alterations of INR, there is conservative steroids, etc., interruption of the drug and oral vitamin K, these are suitable options. In emergent situation, the reversal of warfarin is based upon prothrombin, PCC and FFP. So if PCC and FFP administration are the only source. In case of the case of the INR between 2 to 4, PCC of 25 international units per kg IV, INR 4 to 6, then 35, INR more than 6, 50. Vitamin K, as I told you, 10 milligram IV administered slowly. FFP 10 to 20 ml per kg. In trauma patients, in addition, 1 gram of Tranexa can be used at arrival and repeated another 1 gram in 8 hours. You have to remember that PCC is contraindicated in patients with past history of HIT because this contains the HIT, so the heparin. So therefore, it can provoke similar kind of reaction. In case of reversal of these DUACs, there are 3 drugs available: idrasuzumab, which is specific for dabigatran; adnexate alpha, which is specific for rivaroxaban, apixaban, betrixaban, and all those fondaparinux. And now we have another, which is siraparatide, which can reverse all DOACs, LMWH, and unfraction. We don't have this drug currently available in India, and I'm not sure when it becomes available, so we have no personal experience of using it. And also, I think most of the other places also there is limited usage of the availability and usage of these drugs. But one thing we have to remember that for several years, the first line of option for reversal was PCC, but evidence about PCC effectiveness is still controversial. And with the approval of the newer specific reversal medications, its future is quite uncertain, except for reversal of warfarin. It has certain definite roles. So what are the considerations for patients undergoing neuraxial anesthesia? Patients who are on unfractionated IV heparin, the infusion should be interrupted 4 to 6 hours before puncture or catheter removal or manipulation. If the patient is receiving subcutaneous heparin, the drug should be interrupted 8 to 12 hours before puncture or catheter removal or manipulation. Independent of the route of unfractionated heparin administration, the drug can be restarted 1 hour after the puncture or catheter removal or manipulation. For patients receiving prophylactic dose of low molecular weight heparin, the drug should be interrupted for 12 hours before puncture or catheter removal and manipulation, and 24 hours if the dose is therapeutic. Again, independent of the low molecular weight heparin dose, the drug can be restarted 4 hours after puncture or catheter removal or manipulation. So in summary, we have to consider the following scenarios. Is interruption of coagulation needed? If the answer is no, we go with the procedures. For example, continue anticoagulation. For instance, pacemaker implantation, dental extraction, cataract surgery, etc., etc. If the answer is yes, we have to ask, is bridging coagulation needed? If the answer is no, we just stop warfarin for 5 days before the procedure. If bridging coagulation is needed in view of the risks involved about thromboembolism, like high stroke, recent dip, then we use therapeutic low molecular weight heparin 3 days before surgery, last preoperative dose 24 hours before surgery, or half of the daily dose, resume low molecular weight 48 to 72 hours after surgery, that is particularly for high risk of bleeding patients, and resume warfarin post-operatively and consider bolus dose after the INR settles down. We also have to remember, we have to seriously consider whether there is a real need to stop anticoagulation for the scheduled procedure, not use low molecular weight heparin to bridge direct oral anticoagulants, not use therapeutic low molecular weight heparin the night before the procedure, and when bridging, use a delayed initiation of full dose of anticoagulation in the high-risk patients, preferable to use a half dose. Thank you once again. And once again, I extend my greetings. This is my hospital, the view from the road. And I once again thank and express my gratitude to the organizing team. Thank you.
Okay. Thank you so much, Dr. Anipram. And at the moment, there is no question. But
I have, Dr.
Yeah, you have some questions?
Yes. Thank you, Dr. Yasser. I have a question for Dr. Chaudhary.
You want to ask him?
Yeah, please.
Okay, go ahead.
Yeah, please.
Okay.
Please.
Thank you, Professor Chaudhary, for your fruitful presentation. You mentioned that the patient with the coronary stenting, either drug eluent or bare metal, and before 6 months or 6 weeks respectively, and has emergency operation, we no need to stop the dual antiplatelet, right?
Yes, correct.
Yes. Okay. If we have an intraoperatively bleeding, how can we manage this patient?
Intraoperatively bleeding following the use of double antiplatelet?
Yes, and the patient already on dual antiplatelet and not stopped because it's before 6 weeks for bare metal or 6 months for drug eluent.
No, in that case, we will administer PCC, FFP. These are the first line of defense. When once we have, because we know that aspirin-induced bleeding, if it is purely aspirin-induced bleeding, it is difficult to control. We don't have antidotes. So we will have to rely mainly upon the other measures, supportive measures, including transfusion. And again, the TEG may be an option it will guide us.
Platelet transfusion, is it a solution or not?
I will try it, but I cannot guarantee that it will bring an end to the problem. If it is purely because of aspirin or clopidogrel induced bleed, it's very difficult scenario, because I have personal experience, because my father witnessed such a bleeding, because he had GI bleed, very severe, and it was organ lesion photocoagulation, and in the same admission he had an MI, and it was a diffuse MI, so he had to be and after that it was I myself saw that the aspirin induced bleed is very difficult at times. Thank you for raising this important question.
Yeah, you focused on the bridging, and this is maybe the routine all over the world about the bridging from oral anticoagulant to low molecular weight heparin or unfractionated heparin. Do you have any idea about, or maybe some case reports of thromboembolic phenomena during this bridging? This means the bridging is not enough.
Bridging is not enough is difficult to make out by making an essay. But what we practically we did in our ICU, what we did, we follow the TEG. If we see the variation that from the tracing, that the cast is, the shape of the A is not proper, then we realize that the bridging is not been done. So we leave it at that.
Because as you mentioned, we have to stop the anticoagulant for 1, 2, 3 days to restart the heparin, whatever, fractionated or unfractionated. So a little bit longer time to leave the patient without anticoagulation. So what do you think? To follow the same instructions, or?
We have to follow it on a case-to-case basis. That's what we do. See, there cannot be a rule of thumb in such cases, because the tendency to bleeding is so complicated, and the tendency how bleeding stops, it is so difficult that sometimes all evidences also fail. It is not it is a mix of evidence and experience that guides us into the three, rather than evidence alone.
Yeah. Okay, thank you so much. And we are going for the next lecture. Dr. Safa, you can introduce the speaker, please.
I have a short comment, please, after Dr. Shodari. If we have a high-risk patient that have AF or previous stroke or previous DVT, like that, all the highly risk patient, I suppose that we have no elapsed time to restart or to bridge for the low molecular weight heparin or fractionated heparin. No way. I will have no elapsed time. I will introduce now Dr. Sharmili Sinha. Yes, once again, salute for India and Egypt this warm night and very nice night. Dr. Sharmili Sinha is a current designation senior consultant and critical care medicine, Apollo Hospital, Punhanswire. Advanced intensive care training in Australia, executive committee member, national ISCCM, associate editor, critical care communication, ISCCM, past chairperson, Biswar. Other highlights around 70 guest lecture and 16 publication in index journals and book chapters presented at international level at Critical Care Congress 2016 and Brussels Meet ICEM 2017. Area of experience is neurocritical care, polytrauma, sepsis, ventilation, infection control, and nutrition. Yes, Dr. Sharmili Sinha, please.
Thank you, dear Dr. Professor Safa, for your kind words of introductions, and my heartfelt thanks to Dr. Sand and Team Mega and Egyptian Society of Anaesthesiology for conducting this excellent session on very important and practically relevant topics. So with all my speakers have narrated quite in detail about the coagulation process and the perioperative management, cardiac surgery. So I believe my job is easier now. I am to speak on the critical care and anticoagulation. So all these things that we have been, my previous speakers have been discussing actually entail on and bring us to this topic. And all this perioperative management, be it cardiac surgery before and after, these patients are being managed in the intensive care unit. So the learning objective will be following, and there will be some few areas of overlap, and we'll try to save those in interest of time. So these types of anticoagulants, it have been discussed in detail. Just one fact I would like to highlight is that among all these categories, one of the differences is heparin acts only on the circulating thrombin, right? And direct thrombin inhibitors actually act both on the circulating and the thrombin bound on the clots. So these are more effective anticoagulants. These mechanisms have been discussed, so I'll not go into the details. So coming to heparin, the one and only and the predominant indications for use of heparin in intensive care unit remains thromboprophylaxis in critically ill patients who are admitted to ICU for a variety of reasons. And then comes therapeutic anticoagulation when the case arises. We'll look at the risk categories for this venous thromboembolic events for these patients. Now coming to a very common thing about this dosing of unfractionated heparin, it is usually 5,000 units, either most commonly used is twice daily, or some cases it is 3 times a day, and used in the subcutaneous route. Low molecular heparin, various doses or preparations are available. Most commonly that we use are 40 and 80, 60 milligrams. But in the COVID pandemic also, we have seen varying strengths like 20 milligrams, and now 80 milligram doses are also available. Now, regarding the therapeutic uses of anticoagulation, we'll not go into the details. I'll just roughly mention about the doses. It is usually at a dose of around 18 units per kg, given as an IV bolus and followed by infusions. And you usually titrate the activated thromboplastin time, and the target being around 50 to 80 seconds. For this, actually, we usually advocate to conduct the APTT test, usually 4 to or 6 to 8 hourly. Now, remember, these patients who is on heparin infusions, it is difficult to prick these patients repeatedly to collect the samples. So it is highly advisable that if as possible, these patients have either a central venous catheter or an arterial line in place, so that sampling is easier by the nursing staff which is by the bedside, instead of giving the risk of repeated pricks and causing hematomas in these patients. Now, how heparin is monitored? The common things are the activated platelet times. And if the facility has, infrastructure availability to measure anti-factor 10A activity, one can go for that. But in my practical experience in the last 15 years, we have not ever used this or measured this anti-10A level activity to monitor the action of heparin. It is usually quite satisfactorily monitored with an activated platelet time. And as my previous colleagues described about uses of high doses of heparin, one can go for activated clotting time. The complications we'll see shortly. Now, as I mentioned, this is the first and foremost indication for use of heparin in intensive care unit is about venous thromboprophylaxis to prevent deep vein thrombosis or venous thromboembolic events. Now, the very common or the usual risk assessment models which are followed in this aspect is the Caprini risk assessment model. I find it quite easy and comprehensive to follow. So you see, it encompasses both medical and surgical patients. These patients who get 1 point the list is long, and they are low risk category of patients. Now, patients who get 2 points are usually elderly. They would have either arthroscopic surgery, major open abdominal surgeries, laparoscopic surgeries. Cancer is a very high risk factor for predisposing to hypercoagulable states. Patients who are bedbound for more than 3 days, immobilized, cast is there due to different polytrauma patients, and anybody is having a central venous catheter. Remember, even central venous catheters like internal jugular lines or subclavian lines, or even we have seen the peripheral inserted catheters, and definitely the femoral venous access catheters are also high risk factors for causing deep vein thrombosis. Now, patients as we progress to higher age, again, are at higher risk, more than if the age is more than 75 years. Those who have a history of venous thromboembolism, obviously they are very high risk. And if they have this coagulation factor abnormalities, they are also again at very high risk, including the HIT, heparin-induced thrombocytopenia. Now, the highest risk factor comes to patients who have got a stroke, either a hemorrhagic stroke or an ischemic stroke within 1 month. Those who have got elective arthroplasty, either THR or TKR patients, those who have got this hip and pelvic leg surgeries, and acute spinal cord injuries within 1 month. So these are the very high risk group of patients who must be given consideration for DVT prophylaxis. And overall, this is one of the commonest causes of death and morbidity in patients who are admitted to the hospital, being in the intensive care unit or in the hospital wards. And not to forget that most of this deep vein thrombosis or the emboli originate actually in the pelvic and iliac veins and also in the deep veins of the legs. Why I mention this? Because one of the commonest ways of either monitoring or diagnosing this deep vein thrombosis is by duplex ultrasonogram, when you have either it is available in the ICU or if you're doing it in the radiology suite. But because majority of this actually originate in the common pelvic and iliac veins, it is difficult to access these areas by this duplex ultrasound. Hence, the origin gets missed many a times. Of course, if the clot has migrated and it has got to the cardiopulmonary system, by various means we can diagnose it, which includes the CT pulmonary angiogram. Now, this is usually done. There's a feasibility issue here. If the patient is hemodynamically stable and respiratory wise patient allows, then you can wheel the patient to the radiological suite for conducting the CT pulmonary angiogram. 2D echo actually has given us an advantage these days, and it can be quickly done by the bedside to see if there is an RV dilatation or if the pressures are acutely raised. This is a big indication or a solid indication towards emergence of acute pulmonary embolism. D-dimer in the blood can always do. Venous, again, duplex ultrasonograph. Now, with more and more usage of ultrasound in intensive care units, many places, if you have experience, you can yourself see for this deep vein thrombosis in the accessible areas. So overall, it becomes a diagnosis of exclusions. Now, coming to another risk assessment model for patients, mostly patients who are undergoing surgery. This is a Rogers score, and they have actually looked at in more detail about patients who undergo different kinds of surgeries. That includes the major ones, like those who have got cardiothoracic surgeries or thoracoabdominal aneurysm, because the incision is very long, and these usually are prolonged surgeries, and a lot of blood products are transfused in these cases. Patients are immobilized for longer period of times, and usually the comorbid factors are also high. So these patients are at the high risk. Patients who have got ASS score high also are come under high risk category of patients. And now patients who have got disseminated cancer, chemotherapy itself is also predisposes to a hypercoagulable state. And those who have history of transfusions in 72 hours within the surgery. So these all indicates patients who have more comorbidities or more severe illness. So if it's been combined, this is a good actually in a combined score, which looks at both the Caprini score model, which is a generalized model, which looks at both medical and surgical patients. And this Rogers score is mostly for this surgical patients. If you see for patients who are at moderate to high risk, they have a very high risk of developing venous thromboembolic events without any prophylaxis. So for these two category of patients, unfractionated heparin or low molecular heparin is highly advocated during the period of hospitalization or during ICU admissions. However, patients who have got low or very low scores, they can manage without prophylaxis. However, it depends on the discretion of the clinician or the surgeon at the bedside who can take a call on these patients. Sorry. Okay. Now, quickly coming to the cardiac diseases and anticoagulants. I think my previous speakers have narrated about the usage of anticoagulants and cardiac diseases, both in cardiothoracic surgery and in perioperative situations. So they will not go into the details of it. And along with, I'll just mention about, apart from this atrial fibrillation of both valvular or non-valvular origin, also there is a role in patients who have got dilated cardiomyopathy or severe LV dysfunctions. Now, severe LV dysfunction could be ischemic causes also, and due to a variety of other causes like cardiomyopathies or stress-induced cardiomyopathy sometimes. So these patients also, those who have got low pumping ejection fractions, they are also many times kept on as anticoagulants in the long run. So this CHATS to VAS score has been discussed in detail by Dr. Chaudhary, so we'll not go into the details of it. Just in quickly telling or enumerating that if the score is more than equal to 2, these patients need full anticoagulation. But if it is less, around 1, then antiplatelets plus minus any anticoagulation is needed. I think this is also Dr. Chaudhary has narrated this from intensive care point of view. I'll just mention that if you combine this CHATS to VAS score and this, sorry, Has-Bled score, you can see these patients who are either, if they're at the high risk of either hemorrhage or a high risk of thrombotic events. Now, as years and age passes by, the the risk of hemorrhagic events, which is represented by the solid black line, actually increases proportionately compared to the thrombotic events. Actually, this also comes into, comes to answer one of the questions which was, I think, raised by one of my honorable colleagues just before my talk, that I think what to do, like if you are stopping this anticoagulation in the perioperative period. I would say in my experience of 15 years in critical care, mostly I see the neurocritical care patients who develop also complications due to anticoagulants use, or medical patients or surgical trauma patients who would be on anticoagulants and now has come with polytrauma. I would say that if you're withholding anticoagulants for any acute critical illness where there is high risk of bleeding, usually the incidences of thrombotic events are very less. And this is something also goes with this presentation or this finding by this group of authors. You see that incidences of hemorrhagic events are far more than thrombotic events. And among the bleed or the hemorrhagic complications, the most or the worst ones are the intracranial bleeds. And if a patient on anticoagulation gets an intracranial bleed, usually the consequences are bad, because many surgeons will hesitate to operate on these patients. First of all, if they need any decompressive craniotomy, if they encounter gastrointestinal bleed, as also Dr. Nirban was mentioning, they also bleed very badly, and it's difficult to conduct also endoscopy in these patients, and sometimes it could be just diffuse bleed. And so you cannot cauterize these patients or cannot coagulate the vessels. And the bleeds are usually also divided or classified into minor and major bleeds. We'll just discuss subsequently. About HIT, one of the rare complications of uses of heparin, it has also been discussed by one of my colleagues in great details. We'll not go into the discussions, but I think this 4T scoring system also he has discussed. I would say in short that it is a diagnosis of exclusion. Always keep in mind as a differential diagnosis if the platelet count falls for a patient who has been on heparin. So always keep this as a differential diagnosis. But one common principle in critical care is rare things are rare and common things are common. So, if there is a new fall in the platelet count in a patient who is in ICU and who is also on heparin, then HIT will, as a possibility, will come low in the list. And usually the thrombocytopenia is usually mild in these cases. Though rare, it is very much possible, right? So the treatment wise, very obviously you'll stop heparin, you'll not use low molecular heparin in these cases, and you have other options. But about one of the questions I think which Dr. Yasir was asking initially to the first speaker about a patient who is on HIT and has got low platelet and now has come from acute abdomen and is bleeding, what to do? I think the newer answer is about using high dose of IV immunoglobulins. There is not solid evidence about its efficacy in these cases though, but this is one of the options that we have. A patient who has got HIT and is probably bleeding, you can try this if it is available. And also not to forget to correct the basic things like hypothermia, acidosis, calcium deficiency or anemia in these cases to optimize oxygen delivery and perfusion status in those patients. Regarding this newer or the direct oral anticoagulants, also it has been very extensively discussed. We'll not discuss the mechanism of actions of this, but some distinct and unique features are that this can be given through the oral route, which is a definitely big advantage. Now remember, when we talked about the heparin to BD or TDS subcutaneous doses, or even for low molecular heparin, if it is an OD prick, it is a very discomforting feeling for a patient who's in ICU. And if these patients are also getting pricks for many reasons like sugar monitoring, etc. So oral route is actually a big advantage because it relieves pain. And also these group of drugs do not need any routine monitoring. When we started getting this new anticoagulant molecules around a decade and a half ago, there was less familiarity with this group of drugs. But now with the passage of time, with more and more experience of clinicians, cardiac, all the physicians with these drugs, now there is increasing familiarity. And it is preferred for non-valvular atrial fibrillation or venous thromboembolism cases, and also preferred for high-risk DVT groups at discharge, mainly for this orthopedic surgery patients like arthroplasty or the pelvic surgeries. However, there is high rate of GI bleeding is one of these categories, like that is the rivaroxaban. And because this drug is actually given as an OD dose compared to BD dose for other drugs of this category. So this may be one of the reasons that it can predispose to higher incidences of GI bleed. So it should be usually taken after food, and one patient should be given a word of caution at discharge. The issues we have mentioned already, and one of the common things in clinical practice we see is the underdosing is frequent, because there is, as I mentioned about familiarity, though has been increasing over the decade now, many physicians are actually not quite conversant with the adequate amount of doses which is prescribed by the manufacturer themselves, because there is a subtle fear of in their mind about the increased chances of bleeding. So these patients, the prescription is actually many times mentions the low level of doses, which is improving these days now. Now, another area is patients or uses of these DOACs in patients who have got chronic kidney diseases, because the approximate degree of excretion by the kidneys are as follows. You see, dabigatran has got the highest, percentage of excretion through kidneys, and apixaban is the lowest one. However, having said that, because of the convenience and the points in favor of uses of these DOACs or NOACs, there was a systematic review. Meta-analysis was published in 2019, and it did looked at numerous trials, and the conclusion was very encouraging that NOACs are safe in mild to moderate renal diseases. However, in patients with advanced kidney diseases with creatinine clearance less than equal to 30 mils per minute, there is insufficient evidence, hence it could be avoided in this group of patients. So in patients who have got mild to moderate renal diseases, it is the risk benefit profile is actually superior to that of the vitamin K antagonists like Warfarin. This is a table which demonstrates the difference between Warfarin and direct oral anticoagulants. I think this also has been discussed by my previous speakers. I would just reiterate one point about this monitoring aspect, because in Warfarin, obviously INR monitoring is very important. However, it is not required in cases of direct oral anticoagulants. Drug interaction is a problem for patients who are been on Warfarin, and we have seen many patients who present to us with very deranged INRs from something from 3 to 10, 20 sometimes, which is not an issue usually with the DOACs, though there are some of few drugs which can interact with this direct oral anticoagulants. Again, reversal choices are more in patients who have been on Warfarin. Also, for some of this newer anticoagulants, there are certain categories of reversal agents are available. Monitoring is usually with INR or APT in cases of Warfarin, and thrombin time is used for dabigatran. Anti-factor 10 assay can be also used for apixaban, and also you have this TEG, that is thromboelastogram also. Excuse me. I'm sorry, actually I have an irritant cough going on. So regarding the advantages of DOACs over warfarin or vitamin K antagonist, overall they have a less bleeding risk. There is a possible low risk of fractures, less need of lab monitoring, and better pharmacokinetics. So this meta-analysis actually looked at this comparison, and they found that it is associated with a low rate of fatal bleeding, case fatality rate of major bleeding, and cardiovascular mortality and all-cause mortality compared to the vitamin K antagonists. However, warfarin has got its distinct indications, mainly in patients with mechanical prosthetic heart valves, in patients who have got CKD with a creatinine clearance less than 30, patients who have got severe hepatic diseases and very high hypercoagulable states like those with antiphospholipid syndromes or sorry, those who have got gastric bypass surgeries, because absorption of these drugs becomes an issue in patients who undergo gastric bypass surgeries. So these are the doses. I think this has also been discussed. In cases of bleeding due to the anticoagulants, Dr. Anirban Chaudhary actually did discuss the management of bleeding due to anticoagulants. However, they are majorly divided into two categories, either major or minor categories. Some bleeding is called major when there is hemodynamic instability is associated with it, somebody requiring more than 2 units of blood transfusions as a response to this DOAC-related bleeding, or when there is a fall of hemoglobin by more than 2g%, or somebody requiring massive transfusions. However, small amount of bleeding in a critical anatomical site like intracranial space or retroperitoneal area or intraocular bleed, intraarticular or intramuscular bleed will also be considered a major category. What it means is that we have to consider reversal of these anticoagulants in these cases of bleedings. Minor bleedings are more common, like oral, mucosal, or hematuria also many times happens in patients who have got indwelling catheters, and many times actually it is precipitated by a trauma like pull, or that could be nasal epistaxis also. Of course, we have to stop the anticoagulants, resuscitate these patients based on the general principles of resuscitation in intensive care unit. We have to address the basic causes like hypothermia, acidosis, and other abnormalities like if we have a low platelets. And for majority of these DOACs, action is presumed to be over after 2 to 3 days, whereby at least 5 half-lives would have been elapsed. I think that was also projected by one of my previous colleagues. So if DOAC or NOAC has been stopped for at least 2 to 3 days, 5 half-lives would have elapsed. Hence, one can safely presume that action of these anticoagulants is also over for this category of patients. Reversal of anticoagulants, I think it has been discussed. Sorry. About bridging also, it has been discussed in depth, and I'll just mention about some of my clinical experiences. Mostly in critical care units for patients when we are planning for tracheostomy for a patient who has got head injury or got a stroke. If you're planning tracheostomy, we do withhold this anticoagulants, and but not routinely for central lines, because for patient if they hear anticoagulants or even on IV infusion, sometimes you can take the help of the ultrasound to look at the vessels, and a single prick under visualization actually is not dangerous. So this did not be stopped for this purpose. Reinitiation after stopping is all very important, especially for patients who have got high risk of thromboembolism in the post-operative period. Also, this has been discussed by Dr. Anirban Chaudhary. I would like to just emphasize about few particular cases like high risk patients of ICH, patients who have got intracranial bleed. Many times there is a hesitation to start anticoagulation thereafter, and but there is a wide variation in practice. We have seen some cases as early as 72 hours to even 2 weeks. But however, if there is a high risk of thrombosis is there and you are stopping the anticoagulants for whatever reasons, it is worth considering putting an IVC filter in this category of patients. Reinitiation, again, I think Dr. Anirban has discussed this in depth. Only in patients who have got very high thrombotic risk, we have to certainly seriously consider restarting this anticoagulants as soon as possible. And as the end of the day, it is the clinician's judgment which stands superior to all the guidelines and recommendations, because you have a patient, real patient in front of you, patient with his history and his clinical behavior. So all this evidence whatsoever is available has to be amalgamated and applied to the patient. These guidelines or the scores are just guides or indicators. Discuss this. In certain system-specific diseases, like chronic liver diseases, actually, there are many times it is a dilemma that patients who have got chronic liver disease or acute and chronic liver diseases, and they present to ICUs with different complications like either sepsis or acute kidney injuries or pneumonias, INR is usually found to be elevated. But remember that even though INR is elevated in these cases, it's a blood report, and actually these cases are, these patients with chronic liver diseases are having more prothrombotic state as well, because it is not only the production or synthesis of anticoagulation factors are or the coagulation factors are diminished, also there is diminution of this procoagulant factors or the anticoagulating factors are equally affected. So these patients are actually deceptively more prothrombotic, because many a times if you see, they would have thrombus in the splanchnic circulations, either in this hepatic veins or in this portal vein circulations, whereby it actually augments the scenario of portal hypertension. So high PT or INR does not always indicate high bleeding risk in CLD patients, and there are hepatic pathways for some of this clearance involved in the clearances of direct oral anticoagulants. Regarding kidney diseases, we have already discussed. For monitoring, these are the options we have, and TEG in the best of centers is always helpful if you have. This has been already discussed by one of my previous speakers. And many a times, or in difficult patients where it is difficult to pinpoint which part of the coagulation cascade has to be intervened, we do take help of this TEG, and more so in patients who undergo cardiac surgery or percutaneous interventions in the cath lab. Regarding another distinct category of patients about this cancer-associated thrombosis, now in short, heparin has got a proven superior efficacy in prevention of thrombosis and less bleeding compared to the NOACs. But now the NOACs, with greater familiarity and greater understanding of their pharmacokinetics and biology, there is more emerging evidence that when used properly in the proper doses and in the the right category of patients, they are also having equal efficacy at least. So regarding the kind of cancers or malignancies where we have got higher risk of venous thromboembolism, some scale called Khorana scale is applicable, and you see the type of cancer who are highest risk of creating or predisposing to hypercoagulable state at the stomach, pancreas, and some primary brain tumors, followed by others. Now, regarding, as we said, mentioned that there is now emerging evidence in favor of use of this DOACs in patients with cancer. These are 4 major studies in the last 2 years have come up, which support the role of DOACs in patients with malignancies compared to unfractionated or low molecular heparin. This is a Hoskai cancer VT study, Select Day study, Adam VT study, and the last one. They all have compared this DOAC compared with dalteparin in patients, and they have found comparable results between, like, DOACs have been found comparable with low molecular heparin in prevention of thrombosis at the end of 3 to 6 months. Also, no mortality difference at the end of 3 to 6 months. However, in some cases, there were some major bleeds were found with the usage of DOACs. The other major area which we have not, sorry, we have witnessed in the last 2 years of this pandemic is COVID-associated thrombosis, which also has been fondly termed as thromboinflammation. This coagulation cascade most we have all familiar with, and now this immense or the profound inflammation which is created by this SARS-CoV-2 virus, it definitely triggers this coagulation cascade, and it gives rise to various diffuse thrombotic phenomenon, It affects from all parts of the body, starting from head to toe. The first evidence in its indicating towards it came from Wuhan, where this virus started actually. They found higher level of D-dimers in patients in patients who were affected with this illness, and there were huge difference. You see the red one indicates non-survivors compared to the survivors who had a very low level of D-dimers. So from there, actually, it started pointed that probably thrombosis is one of the predominant mechanism pathophysiology in these patients. And thereafter studies flew in. You see almost this 8 studies from different parts of the world. They have pointed out very high incidences of venous thromboembolism as high as 69% in one series from France, and mostly have been above 20%. Now this is, to compare for one group of authors from 2013, non-COVID cases, you see the incidence was from less than 20% if you take an average, but the incidences were very high in patients series who had COVID-19 infections. So a lot of societies have and the countries have formulated their guidelines, and this is one of the summative ones on from the International Society on Thrombosis and Hemostasis, which says to or recommends to assess the risk of venous thromboembolism in all patients who are admitted to hospital, and prevention should be given to all high-risk patients according to international guidance on thromboprophylaxis in medical patients. Thereby meaning that as we are considering all other patients according to the Caprini model, all patients who are being admitted to the hospital and ICU, they should be assessed for the risk. Consider the possibility of pulmonary thromboembolism in patients sorry, with sudden onset of oxygenation deterioration or develop respiratory distress, and consider switching to low molecular heparin for patients who are on DOACs or vitamin K antagonist. Abnormal coagulation results do not require correction in patients who are not bleeding, because remember, we have to treat the patient and not the reports. And for patients with major bleeding, we can always consider giving empirical FFPs and try to reverse it and give the red cell transfusions as necessary. If your fibrinogen levels are less, try to give the cryo precipitates or fibrinogen concentrate, and platelets, if it is less than 50,000, then we can give platelet transfusion as well. But if the patient does not have DIC, then also give tranexamic acid 1 gram IV. But in COVID associated DIC, one should not use tranexamic acid. Now coming to this one case, which was a real case in our ICU last year. It's a 72-year-old lady, morbidly obese with rheumatoid arthritis, who had a bilateral TKR done 1 year ago, has got other comorbidities like diabetes, hypertension, or so. What is the dose that you'd like to? So please choose one answer of these following 4 choices. I think almost 40% equal percentage have said that 40 milligram BD and or 60 milligram BD. So there is nothing right and wrong in this answer. We did give higher dose to this lady because she was morbidly obese. We gave around 40 milligram BD to this lady. But now let's look at the evidence which emerged later on. Sorry, excuse me for this cough actually. So now I have another case, which was also a real case in the ICU. Yeah, please end poll for the first case. We go to the second case. Sorry. I think equal percentage again have answered here, or some they're going on. Okay. I see, 36% saying 40 milligram OD and 29% is saying 60 milligram OD doses. We can end the poll for this. So as we saw that it is a highly, high stage of high degree of thromboinflammation happens in these cases, and somebody who is on ventilator on high FiO2 requirement, usually we tend to give a higher dose of low molecular heparin, at least 1 milligram per kg body weight. So, somebody, considering 60 milligram subcutaneous OD is good enough. Even people can consider giving 40 milligram BD doses in these cases. But let's see what the evidence that actually is shortly followed after these cases we had in our ICU. So this is an inspiration trial which got published in that towards the end of 2021. There was a randomized controlled trial, and actually they compared this an intermediate dose of enoxaparin that was around 1 milligram per kg daily doses, which we used in our patients, versus a standard prophylactic anticoagulation. And the endpoint were they followed up to till 30 days. The primary efficacy outcome was a composite of venous or arterial thrombosis, treatment or requirement of ECMO, or mortality within 30 days. And what they found, you see this curve, this yellow one indicates the intermediate dose enoxaparin, and the blue one indicates the standard dose enoxaparin. So there was no difference in this two group of patients. So among patients who were admitted to ICU with this COVID-19, intermediate dose prophylactic anticoagulation compared with the standard dose, which is around 40 milligram OD dose, did not result in a significant difference in the primary outcome of a composite, either venous or arterial thrombosis, treatment with ECMO, or mortality within 30 days. So this do not support the routine use of empirical use of intermediate dose prophylaxis anticoagulation in unselected patients who are admitted to ICU with COVID-19. But with that, actually, I would take this result with a pinch of salt, because in our experience, we have seen definitely higher incidences of venous thromboembolism in COVID-19 cases. It's not only detected by, dictated by the sudden requirement of the oxygen deterioration in the oxygen saturation, or sudden sky high levels of D-dimer in these patients. Also from clinical experiences, they have, if you have done echo in these cases or CTPA, they have developed increased instances or incidences of venous thromboembolism with, with pulmonary embolism incidences also, either with or without hemodynamic instability. So if somebody is actually, clinician is deciding to give a bit higher doses, that is an intermediate dose of prophylactic anticoagulation in this population, that also stands good or holds good in these cases, because it is ultimately, if you see both the cases that I cited in the question, they had got risk factors. One, the first lady was morbidly obese patient. She had got bilateral TKR done, though 1 year ago. She is a diabetic, hypertensive, and a history of rheumatoid arthritis. So entailing all these risk factors per se, along with COVID-19, puts her at very high risk of venous thromboembolism. So it will make a case to give an intermediate dose 1 milligram per kg of low molecular heparin in these cases. Now coming to the second case, even this patient was relatively healthier compared to the first patient. He was also on ventilator, that is, he's in severe category of COVID-19 infections, requiring prone positioning, and D-dimer was high. So these cases also, actually, it is difficult to do, echo on a daily basis or do D-dimer on a daily basis in these cases. So if you are considering to give an intermediate dose in these cases, that also holds good in this category of patients. And one thing I would like to share, that in the last, close to 2 years experiences of managing COVID-19 cases in the pandemic, we see that if you're using bit higher doses of anticoagulation for DVT prophylaxis in critically ill patients, actually the chances of severe bleeding or hemorrhage is less, unless they have other risk factors, like suppose there is a big ulcer in the stomach, or they are on other, they have got other kinds of vasculopathies which predispose them to higher bleeding risk, or if they have a severe kidney or hepatic impairment. Other than that, they do not actually bleed as a consequences of bit higher doses of thromboprophylaxis doses of heparin, be it the standard heparin or low molecular heparin. So with that, actually, we are almost coming to an end. There were some latest randomized trials again, which were also commenting on this uses of either intermediate dose versus the prophylactic dose, and they have also got mixed findings. So how to approach a case of thrombosis with COVID-19? We are still going through probably the last wave of COVID-19. You still need to keep in mind that we have to ensure that all patients are risk assessed for venous thromboembolism as well as for bleeding risk, and ensure those at risk receive appropriate thromboprophylaxis adjusted for weight and renal function. Have a high index of clinical suspicions for this venous thromboembolism, but avoid routine using or screening for DVT, and avoid inappropriate blood test, because we ultimately treat the patient and not the reports. Suppose a patient is doing well, is just on diminishing requirement of oxygen, but the D dimer remains high. So you do not have to treat the report, we have to treat the patient. And in critically ill COVID-19 patients, there is definite recommendation against routine use of ultrasound screening for detection of asymptomatic DVTs because of the logistic reasons. Because we are clad in all these PPEs, and you're holding this ultrasound and using it on patients. Obviously, there are infection control issues and issues with the personal requirement as well. So there is no need of doing or screening for asymptomatic DVTs in patients who are in ICU ridden with severe COVID-19 infections. So the take-home message would be to definitely do VT risk assessment for all patients who are admitted to the intensive care unit. Because remember, venous thromboembolism and pulmonary embolism are one of the leading causes of death, among the top 5 causes of death for patients who are admitted to ICU. And it is a global scenario, be it US, Europe, Australia, or India, or Southeast Asia. It is one of the the leading causes of in-hospital deaths. And heparin or low molecular heparin should be considered for thromboprophylaxis for critically ill patients when they're in the intensive care units, and thereafter you can always contemplate to change it to DOACs or NOACs or other alternative agents as appropriate. Therapeutic anticoagulation in preventing DVT or pulmonary embolism has to be started and also maintained properly, and later on switch on to the appropriate agents. DOACs have their unique indications. The best thing about them is their oral route is available. They do not need monitoring, and now there is increasing familiarity with more choices available. Warfarin has it's got its unique indications, mainly in mechanical heart valves and atrial fibrillation from valvular clauses. However, it has to be closely monitored, and reversal options are available when there is a catastrophic complications, mostly the intracranial bleeds. Cancer-associated thrombosis, low molecular heparin has got superior efficacy. Now, however, there is increasing evidence in favor of the DOACs. Moderate to severe COVID-19 illnesses, anticoagulation is definitely recommended. And of course, you have to screen the patients for the bleeding risk, if any. Sorry. Reversal of all these oral anticoagulants are possible, and for the new one also, we have distinct reversal agents are available, but not all the centers, even in developed countries, are available. So if any center particularly is using these newer anticoagulants, that particular physician or the department must be familiarity with the availability or in an emergency situation for this reversal agent. Suppose for dabigatran or the other agent, if you are using in an emergency situation, you need to indent or buy or get this reversal agent, it should be easily available. So the hospital infrastructure or the pharmacy should be equipped and instructed appropriately to keep at least 1 or 2 vials of this reversal agents, because these are usually also costly, and they also, if they are not used in time, they also tend to expire. So any center is using this new anticoagulant agents, that also got to be facility for immediate availability of this reversal agents. Need of monitoring is there. This is best possible with the vitamin K antagonist, but also if it is required, this new anticoagulants also, their levels can be checked. However, the specific calibration assays need to be used for this. bridging and anticoagulation is needed, but there is definitely need of restart is necessary in patients who are got high risk of thromboembolic events later on. Now, near molecular molecules are also again on the horizons. I did not mention because they are not been, come to even phase 3 trials. And there have been talks about in particular anti-factor 11 agent, and also one immunoglobulin is being contemplated. Actually, it is, it is like if one shot is given for these patients in the post-operative period, especially orthopedic cases, up to 5 to 7 days, this patient would not require any anticoagulation, but it's still in the experimental stage. Having said and discussed all these things in detail in the previous 5 lectures and my talk, many a times actual clinical scenario is very complex, as the questions were being put by Dr. Yassir and other colleagues. In a patient who comes, there is a mix and match, and it is ultimately at the clinician at the bedside and the patient who together, according to their risk profile ratio, the risk of bleeding and thromboembolic event, that one has to take a decision about either continuing the anticoagulants or reversing the anticoagulants or managing the complications of anticoagulations. Thank you very much for your patient listening.
Okay, thank you very much, Dr. Sharmila. And we are now exactly 3 hours. Just we have one question about the case number 2. So Dr. Talat is asking, the patient is already 70 kilo. So why we are not using 60 milligram BID of low molecular weight heparin? Yeah,
as I said, that intermediate, when we are following this intermediate dose protocol, where it is 1 milligram per kg. So for 60 kg patients, you can think of giving a 60 milligram. If you're going by the ideal body weight, you can give 60 milligram BD, or you can give 40 milligram BD doses. But 60 milligram BD for these patients will be a little higher. But I would say, but there have been instances where these patients suddenly develop desaturations and the D-dimer level just goes sky high. Something it was increases 5 times, 10 times. You can take a clinical decision there, because taking these patients for CTPA or, if they're in prone position, making them supine and doing an echo to look for any clots is difficult. So on the basis of your clinical assessment, you can give higher doses. But we did use doses.
Yeah. Thank you so much for everybody, for all the speakers, for Saad, for Safa, for Dr. Sharmila, for Wissam, for Ahmad. Actually, 3 hours, a little bit heavy symposium, but I think we covered all the point, and hopefully all the participants have some benefit from our discussion. Thank you, Saad.
Thank you so much for coming tonight. And the next webinar will be February 27, Airway Symposium. Thank you. February 27. Thank you so much, and have a good night.
And all my
Thank you.
panelists and the audience. Thank you. All day.
Thank you all attendants. Thank you all panelists, and thank you all speakers, moderator, for your effort tonight. Thank you.